does require us one person to speak at a time. So if you want to make a point, please put your hand up. One of the people next to me will bully me and kick me if I fail to see you. Okay, so we'll try and use the discipline. So welcome, thank you very much. Apologies for absence. We've got Shahida, I think, who rang to say she was ill, and Alison Knowles, and Joe, you're in Alison's place. Is that it? Hiya, welcome, come in. Come in, please sit down. No other apologies for absence. Thank you. Declarations of interest. Any declarations of interest for people? Thank you for that. Okay, minutes of the meeting on the 7th of September. Are they okay? People happy for me to agree them? Thank you. For those who don't know, and particularly members of the public, we do try and start off with a story about patients or our services. And I know we've got one called Be the One Today. Chris, are you going to introduce that for us?
If you don't mind.
Please.
So stand up, Chess.
Yeah, please.
Hi everyone, I'm Chris Edwards. I'm the place director for Rotherham. So today is just we're going to play a video about the Be the One campaign for Rotherham, which is focused on suicide prevention. The background to this is, if you go back to 2018, Rotherham was a national outlier for suicide. As a Rotherham partnership, this is something we made our absolute priority. The Health and Wellbeing Board oversaw it. We looked for best practice across the country. We went to look at what happened in Bridgend and tried to take some learning from there. We took some learning from Australia, and we put in all the best practice you could possibly put in. But the one thing that really made a difference was the Be the One campaign, which we'll talk about. And what it did, it got our suicide rates down to expected levels. We'll never get them to zero, but it got them to expected levels. The cost of living crisis will be mentioned many times at this meeting today. We recognise that there is a positive correlation between economic downturn and suicide rates. So this is why we've re-energised the campaign. We launched it in September. We've already had 3,000 people engaged with it. So just play the video and just give people a flavour for what the Be the One campaign is all about.
Thanks, Chris. Good. Square.
I was staring into the corner of the room when my partner turned around and asked me what was wrong. There was only 2 words that I could say to her. That was empty and trapped. And that's when I broke down and told her that I planned on taking my own life.
We're just trying to get the sound adjusted. We need to do something on that screen.
Say to her that was empty and trapped. And that's when I broke down and told her that I I was staring into the corner of the room when my partner turned around and asked me what was wrong. There was only two words that I could say to her. That was empty and trapped. And that's when I broke down and told her that I had planned on taking my own life.
It's hard talking about feelings and problems. That was one good thing about the pandemic. People seemed to have more time for each other. It felt like I was trapped in my head. To me, the pain of taking my own life wouldn't be as bad as what was going on in my head.
I cut myself off, distanced myself from everyone who cared until I thought there was no one that could help. And the thought of suicide were always there, following me around as if my only way out, my end goal.
I had no idea that Joshua was surviving just so that I wouldn't feel upset, that he really didn't want to be here. But he said that me just listening really helped him get his thoughts out, and then we found him some help. And now he's got a new job and that gives him purpose, and he helps other people with similar thoughts and feelings.
He stopped coming to football. I didn't really think anything about it. A few people had seen him around town saying he didn't look like himself. We tried to ring him on his phone, but he didn't answer. So we went to his house and we got him talking.
So I was on my way home from work and I saw this lady sitting on this wall and she was really, really crying and kind of mumbling to herself as well. So I stopped and I just went up to her, asked her if she needed any help, and eventually she opened up about feeling suicidal, and I'm really glad that I stopped and convinced her to go speak to somebody.
We're constantly running around and juggling work, family, and life, and it can be easy to think, I'm sure he's fine, I'm sure she's got someone else to talk to, but you're never sure until you actually ask, are you okay? Do you want to talk? Do you need any help? And if they say they're fine and you're not so sure, please ask again. Don't be left wondering if you could have done something, anything more to help. For those people having suicidal thoughts, please reach out to a friend, a family member, a neighbour, a colleague, the Samaritans, or even just somebody down the pub, whoever you feel comfortable and confident talking to, because you have to remember the world is not a better place without you in it, and there is plenty of help available to you right now. Always remember to look after each other in Rotherham.
Chris, do you want to talk a bit about the impact? Very powerful stuff, that.
Sorry, I've got a bit of feedback. When we first launched this campaign in 2019, this seemed to be the thing that made the biggest difference in terms of changing what happens in Rotherham, about getting people to talk. And our suicide rates were off the scale in terms of how we compare to other areas. And this got us back down to expected levels. We'll never truly understand because every case is different. But for some reason, this made a real difference. And all the Rotherham partners really embraced it. It made a huge difference.
Any points or questions from the board? Ben?
Yeah, just to say, so we've got the Be The One website, which is just betheone.co.uk, and on there you've got access to the video, but there's also access to the Zero Suicide Alliance training, and it's really good. It's a 20-minute online training session, so it's something that I think I'd recommend that all of us at board level do, but also that we pass through all of our partner organisations as well.
Any other points people want to raise? I mean, I was struck watching it by the young lad who just saw a woman on the street. My mother used to talk about small acts of kindness, and actually this is about just noticing things, isn't it? And stopping and talking. And you know, campaigns are important, but actually we all have obligations, don't we? And that lad, God bless his cotton socks, stopped and talked to somebody. Actually, that's a message for everybody, isn't it? Wendy.
Yeah, I mean, it's really powerful, the powerful message that really helped to reach that sort of conversation in communities. We know we have many communities across South Yorkshire, ex-mining communities, particularly with men that find it really difficult to open up and say to me, I just don't feel so good, really. We need to try and make it as easy and people feel as comfortable to have those sorts of conversations as you would when you say, my arm's hurting, I've got a pain in my leg. You know, it really needs to be as ordinary, and it's almost really encouraging our communities to be caring, I think, caring and supportive, and not to feel worried or feel intrusive that they're asking somebody, are you all right? And I think sometimes that's what we've got to battle against, is people feel that they've been invasive into people's lives, when it is actually really a good thing to say, are you all right? Are you okay?
Sorry, can I just respond? The key difference this time as well is that last time when we did this is a reaction to very high suicide rates. We can see something coming now with the economic downturn. We're trying to be proactive. Stop the spread to that place again.
I've got Moira, then I've got Lisa, then Gavin. Moira.
Hi, thanks. Yeah, I mean, thanks very much, Chris. I mean, I'm actually the chair of the Safeguarding Adults Board in Rotherham, so we're very keen to make sure that this message about talking to people gets out as much as possible. But I was just wondering how we could actually get something like that as out in the community as much as possible, particularly in primary care, where people are sitting waiting to see a GP or something like that. So actually some thoughts about actually getting help.
Really good point. Let's pick that up. Lisa?
I think I echo what everyone else has said, and normalising that conversation is probably one of the most important things. And as Chris mentioned, we have the cost of living crisis, pressures, and as a GP, you see people's mental health literally falling off the cliff. So I think the things that we're doing to sort of mitigate the crisis are aimed at building communities and getting people to support each other and getting people together so that they can have those conversations. And I think they're really important. And doing this in primary care and where it is essential. We don't have the people, so having more people in there, getting the community involved would be excellent. And I think this is a really good initiative.
Thanks, Lisa. Gavin?
So just a couple of points for me. I mean, my first is about spread. I mean, I think it's really good to focus on something that's worked well in one of our places. But I think there's a question then is, you know, are we doing similar things, or could we do that in each of our places? You know, this focuses on suicide prevention, but you know, are there good things happening in other places? You know, it's so I suppose that the challenge is around spread, and that's one of the big opportunities of the ICB. I think my second point was around a sort of health inequalities related question, and just about what can we do to, I suppose, fine tune our approach to meet the needs of different parts of the community. So you don't need to respond, but I just kind of put that out there really as a sort of I guess a challenge when we're thinking about intervention. You know, are we speaking to all parts of our community? I think it ought to be a question we ask ourselves.
Leslie.
On another day with another hat on, I'm involved in some of the work that's happening in Rotherham. And I've got a couple of observations really. One is, I think the video's great, but actually all those are young people. and older people are a significant issue, and we know that in terms of how people feel and can be very hidden. So I just think something that maybe speaks to them. And excuse me, the other thing is, and Shafiq would probably say this, but is the work that's being done with the voluntary and community sector on this is really powerful, because we have got tentacles out into community, and getting that spread out there and getting that normalisation is about everybody doing it. And picking up on what Maureen has said, you know, in terms of Safeguarding Adults Board, it's really important that we make it everybody's business and that we notice things. So we've got lots of social care staff going into people's homes every day that can notice things and those kinds of things. So I think it is about that. That's been the power of it for me, has been how we've worked together with it, and actually we've looked at making it really out there. And I would echo what you're saying about getting that across the piece in South Yorkshire, but equally about making sure that when we do the same process, so we engage everybody in it.
Really good point. Wendy?
Yes, as well. But, yeah, of course, we've got the Mental Health and Autism Alliance, and we're going through a really helpful cycle at the moment around refreshing our priorities, both in partnership with our provider chief execs and with our place leads, and for the wider partnerships that exist at place. So really wanted to try and make sure that we focus on the right things, the right reasons, and of course, no doubt, the areas that we want to be focusing on.
Chris, thank you for that. And I thought it was a really helpful discussion. And as you say, Chris, the fear we all have is things are getting more difficult out there, not easier. And actually that and to give support to our individuals in our communities is we know is going to be critical over the next few months. But thank you, really, really helpful. Okay, move on the agenda, please. Agenda item 6, which is questions from the public. Let me just explain this. This is a meeting in public, not a public meeting, but we do receive questions from members of the public. We receive three. We're going to read them out, and then we're going to read the answer out. Mark, are you going to read?
Yeah, of course. Thanks, Chair. And Andy, can I just check you can hear me?
I can hear you, yes.
Thank you. So we've got 3 questions from the public. The first question is from a Mr. Doug Wright, and it refers to the schedule of board meetings. The question goes on: I referred to question 1 on the 1st of July. I welcome my first visit to Sheffield on Wednesday. Will you please now ensure that the remaining 2 locations, Barnsley and Doncaster, will be available for the next 2 integrated care board meetings? By Andy.
Yeah, of course. Mr. Wright here today. Hi. So I think the question's a great one. I think we're absolutely committed to moving our board meetings around our different places. We're trying to do so in locations that don't incur any costs, unnecessary costs at the moment. But I think our locations in Doncaster and Barnsley aren't great for this size of meeting. So we are going to look at different venues in those localities to see where we can hold them. So they might not be the next 2 meetings, but I think our commitment is to get to those locations as soon as we can do. And
I think the other issue for me to balance out is, over the pandemic, we started to go online with a number of our meetings, and we got far more people responding online. So I think we've got about 20 people today online, and we want to make sure the venues we choose can use the technology, and not all the venues we've got doing that. So we're trying to balance out the number of things. In principle, we want to shift them to each of the 4 places. In practice, I want to make sure I've got 4 places that can take online meetings. So good point, bear with us, we'll try and get it right.
That's one point. I can't not to speak, but this is actually, today, I tell you, at 7:10 in the morning. And even worse, with other them, they start cancelling the trains. I know there's one at 8:32, and then the next one, if that's cancelled again, the next train is 10:39. I just cannot get there.
I understand that. We absolutely accept that. And I'm trying to balance the meetings being local with having meetings where people can do it online. Not all of our places have those meeting rooms, but the point is absolutely well made and accepted. Thank you. Mark, second question.
Second question, again from Mr. Doug Wright. I have difficulty as a member of the public of understanding the written general management speak of the integrated care board.
What is inexcusable is the continual use of acronyms throughout the published documents. I'd appreciate you letting me know what improvements you will make on both issues.
No offence, but that's a good point.
So I'm happy to try and answer that one again. So I think we accept that some of our documents are really highly technical documents that are hard to simplify in some ways. But I think what we can do is we can adopt the principles of the NHS Constitution, which says that they should be clear, concise, straightforward, accessible, and like I say, avoid jargon. So I will share around the NHS England guidance with all those who contribute to papers for this board meeting. And in addition, we'll provide a glossary of frequently used terms in our board papers as well, so that that's available to anybody who accesses them. So I think we do absolutely agree, and we'll continue to work hard on that.
Can I just add something else?
Yeah.
I think that's fair. I'm just looking towards the executive directors. You're writing these reports. Can we be really clear here? If you use any acronyms, the first time you use it, can you put down what they mean? And so anybody reading it, because what I don't want to do is ask somebody to go back to another document to understand what ICB means. First time, this is just a bit of discipline amongst the directors. No offence, guys. First time you use an acronym, can you put what it is? And then we know in the rest of the document. It's just a discipline that once we do it, we'll get into it and it's really straightforward. That makes a lot of difference. Okay. Thank you. Was there another question?
Yeah, there is. Final question is from the Mr. Tim Brown, who I know isn't with us today, isn't here. He goes on to ask, given that a disproportionate number of vulnerable black, non-white citizens were subject to the most horrific abuse on an industrial scale at the specialist Doncaster children's homes run by the Hesley Group, and we once again learned that black parents and carers' concerns were ignored within the shocking report safeguarding children with disabilities in residential settings, can the ICB board offer an assurance that they are proactively committed to an ethos of anti-racism and the importance of ensuring that there is the necessary psychological safe space in Doncaster Place to enable black citizens to have their say on the things that matter to them, including ensuring that our most vulnerable citizens are protected from harm in a culturally appropriate manner?
Thank you.
And if I can pick up the initial response to that question, and I know Mr. Brown is going to watch this meeting after it's taken place. So I think we're really grateful for this question to be submitted. A similar question was asked at the Integrated Care Partnership Board meeting on Friday next week. So we will be writing out formally to Mr. Brown to give our response. But I think one of our core purposes is to tackle inequalities in outcomes, in experience and access. And we ourselves at NHS South Yorkshire take a strong stance against any form of racism in health and care. I've had a number of conversations over email with Mr. Brown this week, and I'm looking to set up some meetings with him so that I can meet with him and build that relationship with him. But equally as well, people from this board can also meet with his group, because he does represent a wider group of people in Doncaster, and it's important for us to be able to hear their views and understand their concerns. So I'll be taking forward those actions as well. So I'll be in further touch with Mr. Brown in the coming weeks.
Thanks, Andy, and I'm more than happy to meet him if that would be helpful. Okay, thank you. That's all the questions.
I sent the question, but obviously you have not received it. I don't understand it. But it's quite similar to the last question.
Okay.
But I would like to ask something to them, that in a lot of the reports, there is no equality. I understand they are not relevant in all the cases, but in some cases, I think an equality impact assessment, it is appropriate. That is missing, because if we do that, we recognize there are inequalities.
That's a good point, and I will ask to make sure it's picked up. Thank you very much. Okay. I'm sorry we didn't seem to get your question, but thank you.
Yes.
Okay. Thank you. Move on to agenda item 7, which is my update to the board. Only a few small things. Gavin and I, with the appropriate locality directors, Chris Edwards and Anthony Fitzgerald, have met with both the Rotherham MPs and the Doncaster MPs in the last 2 or 3 weeks. Helpful discussions, as you can imagine, and we're trying to keep them up fairly regularly. And the MPs seem to value, which is great. I went to an Olympic Legacy in Action celebration event couple of weeks ago, which was actually originally cancelled because Queen died, some of you who were invited. I went to, with Gavin, to a recovery event for elective care across the northeastern Yorkshire, which all our acute trusts went to. Real pressure now to deliver better throughput, reduce waiting times more, and I know all the acute trusts chief execs were there, and it's a thing we will pick up through the Acute Federation. And finally, I was involved in the appointment of the chair of RDASH, our mental health trust in the north of the region. Delighted to say that we appointed Cass Lavery as chair of RDASH, who's currently chair of Yorkshire Ambulance Service, and will be moving to RDASH very shortly. That's all I've got. Gavin, your chief executive's report, if I can add to you.
Thanks, Piers. I'm now looking for acronyms in my report, Piers. So
there you are. You've had an impact.
Hopefully I've got them. I must admit, before I get it, I mean, we had Mr. Brown's question at the ICP, and obviously we had today a challenge around equality impact assessments. I think we've got to take that on the chin. I mean, just to make a couple of really clear points. We're absolutely committed to addressing inequality in health, and we absolutely acknowledge that they exist and that members of our communities have a differential experience, in terms of the use and impact of our services. So when we come on to our strategy later, we'll maybe share a little bit about how we're absolutely making sure that what we set out to achieve as an integrated care system does generally speak to inequality in our community's experience of health and care. I think the second point I wanted to make was around inequality within the health and care workforce. And again, I mean, Christine, our Chief People Officer, myself, leaders of the major provider organisations have met recently to talk about how do we get better at not just being, I suppose, not just addressing health inequality, but actually being anti-racist organisations where we're far more active. So I mean, things that I think we do feel strongly about, and I think we expect quite rightly to be held to account on this point. So I think your question about equality impact assessments was a really good one. I won't draw too much out of the report. I mean, we've got quite a bit on the agenda. I'm really pleased with the work that's being done around the integrated care partnership and the developments of the strategy. And will take us through some of the work that's being done. We've got quite a tight deadline in terms of publishing our initial report, and we're really keen as well, even though the time is short, is to make sure that the voice of our community is heard in the developments of that. But we'll pick that up later on the agenda. Just in terms of, I guess, some new faces within the ICP. I've listed a few in the report, but I did just want to draw out. We've got Joe Dobson with us. So Joe is interim locality director, so part of our partnership with NHS England. We have an embedded locality team within the ICB. So it's great to have Joe here, and Joe will pick up some elements of the integrated care, the integrated performance report later. I perhaps just wanted to focus a little bit on winter and to say that it's fair to say that there's the urgent of the emergency care system across South Yorkshire has been running hot all the way through the summer, so it doesn't feel like there's been much of a let up. But we also know that the winter period is more challenging, and against the backdrop of cost of living crisis and other factors which may exacerbate the usual sort of seasonal increase in demand. Just said there's an intensive process of planning going on across South Yorkshire. It's multi-agency, it involves all of our partners. Each of the places have held urgent and emergency care winter planning summits, and we'll hear from the place directors updates later, some highlights from that. But just to say that that's particularly high on the agenda. COVID hasn't gone away, it's still here. So the vaccination programme, I think we're making good progress. I think we're rolling that out. I think, Anthony, you shared with me a bit of a progress report yesterday about nursing homes, which is particularly a particular priority in terms of vaccination. Anthony, do you want to give us the headline?
Yeah, I was happy to see yesterday that we had a target to vaccinate all care and nursing homes by the 1st of November, and we met that target across South Yorkshire. there is an odd exception where there's been a COVID outbreak within the nursing home, but we'll visit them as soon as we possibly can. So a great credit to all the teams that have been involved with that, because it's a significant undertaking and gets us much more resilient coming into the winter months.
Thanks, Nancy. And so needless to say, vaccination is a critical part of our response to the challenge of winter, not just for COVID, but also for flu. We're anticipating a challenging flu season. The experience in the southern hemisphere, which sort of kind of leads ahead of us. So I guess a message for the public would be, if you get the opportunity to get your flu and your COVID vaccinations, then please do that, because that's a critical part of keeping yourself well and hopefully out of our services as well. Yes, that's all I wanted to highlight.
Okay, thank you. Any questions for Gavin? David?
Yes, if I could just pull out of your report, Gavin, about Dr. Laura Evans being the Allied Health Professional Lead. I think that's our commitment towards clinical and professional leadership in its most diverse form. So we also have a health science lead as well, but we'll see more and more of these roles rather than the typical doctor nursing that have tended to be on the boards.
Thank you, David. Any other points? Thank you, Gavin. We'll go now to the place report, and Gavin briefly mentioned it. Barnsley, Wendy.
Yeah, thank you, Chair. Just a few things to highlight, and like yourself, Gavin, I'm just looking through that to see if I've got any opinions in there. So I'm also if we have them in there. Our Place Partnership Board has met a couple of times now. It'd be fair to say we're still getting to a rhythm. It's still settling, and we'll be taking stock of our arrangements very early in 23 to make sure we're making the best of our time together. A few things that we focused on. We're really pleased about the work that we all co-produced in terms of our virtual recruitment fair. Because as we all know and all appreciate, workforce is a particular challenge. And it worked really, really well. We had a number of individuals that attended that virtual fair. Credit to our communications colleagues and comms colleagues that really helped us with that. And that's sort of, we've had quite a bit of a return on that. A number of people then registered interest for vacancies, and so really, really pleased about that. More that we'll be able to do on that. We're doing some work with an industry partner around a technology-enabled approach to frailty. A really good take-up through some of the primary care teams really on that. Some learning, I think, we'll take about how do you recruit people to programmes from that. So we'll share a bit more about that in due course. When we get further on with that programme. Like many places, we did a little bit of a deep dive, a bit of a check and challenge in our plans for winter. That brought some really interesting learning for us, really, about where else do we need to strengthen our arm in Barnsley on our approach to getting through winter. And I just wanted to particularly mention the work around cost of living. We've done some great work, I think, around our approach around living free contact count approach, but particularly we've created a composite website which has got all of the support for people to access in terms of helping them through tough times financially and otherwise. But it's been more than that. We've took that on the road and we've gone to businesses that we know perhaps don't pay the best of wages, and rightly or wrongly, and we've worked with a number of different organisations. So getting that on the road, working with neighbourhood nursing colleagues, mental health teams, just to raise awareness of it. So we've done so much work in that sort of space to make sure that we can help people through. And supplemented with that, we've really invested in our household support grant, and that's been really, really helpful for people to get interest-free loans via credit union, the warm hubs that many of us are doing, recycle school uniforms, anything and everything that we can do to help people manage through these difficult times. So that's probably it from me, just a few highlights there. And we say we've got PCN, that's the primary care network.
Thank you. Any questions for Wendy? Thank you. Anthony.
Yeah. Thanks, Chair. My report comes from the City of Doncaster. Would like me to mention the biggest pressure in Doncaster at the moment, as I'm sure members know, is on our urgent and emergency care system, and that's shared similarly across the patch, but in many areas of the country. Our work, therefore, at the moment is various approaches to address and enable us to be more prepared for the difficult winter months that we face. Given some of the questions that we had earlier, we've taken a proactive approach to tackling health inequalities in Doncaster, and that's included some really good work around digital inclusion and the use of digital technologies that we can, but actually taking that out to our public and making them more comfortable with the use of those technologies. And some really good work that's going on in that area. Similar to, as Wendy's described, we've taken a very proactive approach to the cost of living crisis in Doncaster. That's being led by our Public Health Directorate and across Doncaster. I think the point I'd wanted to take across is some of the principles really that we're really trying to take a compassionate approach to this over winter. It's not somebody's fault that they're falling into vulnerable. So the whole approach that we're trying to take is encourage our staff to take a holistic approach in their conversations with people and showing professional curiosity. There is a lot of work going on around winter planning. There's a lot of requirements that are needed. We're particularly looking at flow through our hospitals, through our hospital sites, and working with partners across the partnership there as well. Gavin's mentioned vaccination, but we're also taking a big approach about getting into some of our underserved communities to increase vaccination for both flu and COVID. To make them more resilient for our winter months. So a lot of work that's going on around winter resilience and a good partnership approach being undertaken.
Thanks. Any questions for Nancy around Doncaster?
Thanks, Nancy. Really useful. Could you just tell us a little bit more about the regional personalised care leadership programme? What does what does that you're looking to get from that in terms of?
Well, I think what we're trying to do is work with a partnership, Moira, around actually understanding the needs and strengths of our community. But we've invested a lot in our locality approach in Doncaster, including specific commissioning with the voluntary community and faith sector in the north of Doncaster, the centre of Doncaster, etc. We're doing a lot of appreciative inquiry across all our staff to actually understand what our personal needs is. We did a lot of good work during COVID on that, Moira, about really trying to understand what that work is. So personalised approach, but actually more tailored around our specific neighbourhoods and streets in Doncaster, using our voluntary community and faith sector, which we're building on. We're trying to, we've got some great examples of good work in Rotherham where we're trying to invest to in that sector to get it more proactive and more.
That makes sense, yeah, in terms of working with communities in the voluntary sector.
Sorry, just one more. What we're trying to get better at is evaluating and monitoring and the actual impact of that kind of work.
Okay. Well, thank you. Any other questions? Chris, welcome.
Thanks, Chair. So just a quick update on health inequalities and population health. So updated last time about how we've all our business intelligence information services, we've got the hospital, the council, our organisation all come together to make sure we have all the information we needed so we can really target our at-risk groups and make sure we can focus our resources on the prevention and intervention in those groups. The next step for us is obviously to use that information to develop prevention pathways. So that's the next phase of our work plan. Just a second on cost of living. Again, food banks, warm banks, we say warm banks, warm spaces is probably the language we're using in Rotherham. We're looking at hardship funds, household support funds, debt advice. And it was interesting, I was just looking at our mental health support service. We have something called Rotherhive, which is a digital support package available for all patients in Rotherham. We've had 78,000 individual users, bearing in mind that's 39% of the adult population of Rotherham that's using this resource. And what we've seen is, although that's great news, the resource is available, when you actually look at what's happening there, mental health support was our biggest area of support. That's now being overtaken by depression, anxiety, stress and wellness. We're seeing big increases in debt advice, homeless and bereavement support. And to sort of give a scale, we get 3,000 hits new users a month coming through using that. So it really is giving us a picture of what's there. But the support is there, is the good news. It's just the demand obviously does cause us concern. terms of the winter plan, very similar to other places, we've got a health and care winter plan, stress tested it and worked through. There are some risks that remain, so particular risks around staffing absences at the moment and staffing levels, and care sector capacity is something that's causing us concern. We have got plans to mitigate, but they are the biggest risks. And just to finish with some good news, the vaccine update, we've done 100% of care home patients for the vaccination. I think that's across South Yorkshire, isn't it? So that's good news. And we've done 41% of our eligible population. Everything's going to plan, and we should hopefully have a very successful vaccination.
Thank you. Any questions for Chris? Sheffield, Emma. Oh, sorry, Lisa, I didn't see you. You didn't kick me. I've told everyone to kick me. Sorry.
There's so much good work. I think my only issue is some of the language, the hard to reach communities. I feel like they're not hard to reach. We get poor engagement from them. But yeah, I think that's the way that we need to.
Yeah,
I
agree. No, I totally agree. And that point was made to us at the ICP meeting. That said, actually, our language needs to change. Yeah. They want to talk to us, we just have to talk to them.
Yeah.
We're them. So good point, Lisa. Thank you for pointing it out. Leslie.
Somebody the other day used I can't remember where it was, used the word easy to ignore communities rather than hard to reach. I really like that.
That's good.
I think that's really good. Because actually that's what they are. We ignore them, they're not hard to reach.
Good point. Emma, Sheffield.
Thank you, Chair. Okay, so in terms of Sheffield Partnership, we've now agreed our new arrangements. We've got a real focus on inequality. As part of our new arrangements, we've created a new programme which is development and inclusion, and that will focus and pay particular attention to our role as anchor institutions and what we can do around the supply chain in Sheffield. It will focus on our recruitment policies, and I think Gavin's already touched on that, but actually what can we do to ensure we have a much more inclusive approach to our communities and have a sort of talent pipeline into Sheffield. And also, what's our approach to equality and diversity in its truest sense? I spent the afternoon yesterday with a couple of voluntary sector organisations, really grassroots organisations, and to see the impact that they are having on people's lives on a day-to-day basis cannot be underestimated. And so, from our perspective in Sheffield, we're seeing very much the BCS as our first option and not our last option, as sometimes happens. So, I think I'm really the work we're starting to create in Sheffield to really focus on those, hard to ignore patients that easy to ignore patients that we just talked about. So really, really proud of that. And obviously, we've recruited a GP as the clinical director for health inequality. So keeping that focus on health inequality is what matters. And more importantly, we've got a lot of information of what do we actually do about that. You can see through the report we've secured some additional funding for a number of initiatives, which you can see in that which really does tackle some of our hard easy to ignore population. In terms of the cost of living crisis, that really builds on that. So we've got an initiative programme with the City Council about what we do. We know that we've got to keep doing more. It's a dynamic process. So although we've got a plan, we keep thinking about what more can we do to support that, support the cost of living crisis collectively together. In terms of the winter planning update, again, Gavin mentioned that we've had an urgent and emergency care centre, and we're learning from other places. Our biggest risk is definitely home care provision and the independent sector, and again, how we can start to mitigate that. What I would say is that we're doing a lot really trying to manage the flow and the demand, as others have talked about. But in the new year, we'll be doing a programme of transformation for urgent and emergency care, which will be end to end. So actually, what can we do differently? So we've got winter funding at the moment, which will mitigate some of the risks, but actually we need to take a root and branch review to urgent and emergency care, which starts at home and ends at obviously end of life, in terms of what are we doing with our resource, what can we do more effectively, and how can we improve the flow for patients and improve the quality of care for the population of Sheffield. I think that's really all I wanted to say. Thank you, Chair.
Thank you. Any questions for Ella? Can I just ask something which I don't know, it might be a question for Lee. There was an announcement 4 or 5 weeks ago from the then government, God knows how many changed since then, about 500 million for social care to help support winter pressures. I keep thinking, I wonder when it's coming and how it's been. Have we heard anything?
not heard anything on the NHS side of the street. Damien might be in a slightly better place, perhaps, in his local government. But I haven't heard anything around the routing through NHS.
You haven't heard anything? No, okay.
This is my health improvement hat on. Yeah, I don't think it's been formally announced yet.
No, that's right. It's good. In the words, I mean, this was a conversation we had with the minister a few weeks ago to say, to put it delicately, it's getting very late, minister. Okay, Wendy.
Yeah, we were chasing the same question only this week, really, about, and I noticed the NHS conference asking the same question about where this fund is. I understand that the detail of the fund and how it will come out, and the conditions of how it can be spent is being finalised, and hopefully it's going to come out very shortly.
Okay, I mean, it might be something we return to. We've got an informal in December, but I mean, it's very difficult for us to sit down and talk to our local authority colleagues in November, you know, about how we're going to use it. And anyway, Emma, thank you for that. Okay, agenda item 10 is integrated performance report. Gavin, can I ask you to introduce this?
Thanks, Chair. So I think, I mean, I would describe this as a work in progress. You know, just conscious of some of our earlier discussion about how to interpret, but I think some of the appendices particularly are very dense. So I think what we'll be trying to do is to refine the way that the system performance is described here to make it more accessible and easy to understand. However, the narrative at the beginning is probably the best place to focus because that does describe some of the issues. So perhaps what I'll do is just ask maybe just executive colleagues to highlight any areas within their particular portfolio that they want to escalate to the board. So maybe just looking to David and Kathy around quality, patient safety.
Yeah, I'll just, I was going to do a page number, but I can't see those on my report. So just kind of describing quality and safety. I think what's been really useful this week, I've had a meeting with Kieran, but also some conversations with Joe around how we really start to pull the quality data and information together. What does that need to look like for board level? Actually, what data do we need to see here? What data needs to be reviewed at quality? I'm going to say quicker because I always think the whole term is your quality, performance, experience and patient involvement. I've got it written down next to me with Leslie. And how we really start to triangulate that information together and then what's developed at place. So actually we've got a real fluid process that escalates up in relation to what do we really need to be started on here in relation to our statutory responsibilities. So that work's in progress, working really closely with Leslie as well around that. And we've got a time out with our place quality leads with some of the data and informatics team, and Joe's team will also be invited to that to kind of really look at how do we start to use that and how do we really triangulate it with the performance data. Because actually when you look at the performance data, it's so interlinked with quality and experience, and there's a real danger that we could go off down rabbit warrens really in relation to that. So hopefully by the time we get to the next board, that will be a lot clearer. David and I have been working really closely with colleagues across the system, but particularly in relation to our place colleagues around it, delivery and assurance model, and there's a diagram with that in the report. And what we've been developing as part of the operating model is each of our chief nurses at place taking a system and leadership role around certain areas of programme delivery. So for instance, Jane Sivakumar, who's the chief nurse at place in Barnsley, will be leading the work across the whole system around the patient safety incident response framework, which is a national programme that needs to be implemented across the whole country in a different way of reporting and triangulating information from a patient safety perspective, and has also taken on the lead for infection prevention and control for us across the system as well, to make sure that we've got some really clear governance processes in place around that. So again, that's developing, but I think it gives us a real opportunity to embed things that are working really well at place from a quality and safety perspective with partners that need to stay at place, but also to look at what's delivered best across the whole system. And I think, you know, really good example of the video that Chris has shared this morning. How do we pick up some of those things that actually would work really well across the whole system and could be scaled up? I'm just going to pick out two areas of risk that David and I escalated through to the regional risk group, and then I'll leave David to pick up the other two areas. So for me, particularly maternity, so whilst We've got a really good programme of work around maternity and maternity delivery across the system. Our partners and our providers work really well collectively together. We have a real challenge with capacity in maternity, and that's mainly around workforce, and that is what causes us most challenge, really, in making sure that the women in our system are able to deliver babies as close to home as possible. So we're working really collectively together on that, and Richard Pogg has taken up the SRO role for that from a chief exec perspective. We obviously have these reports that were published just over a week ago. So at the moment in the system, we're working through what does that mean for our providers, what lessons can we learn ahead of the national aspect, which we're anticipating as we move into January. The other area I just wanted to pick up was around workforce, and I think workforce probably is a really key thread through all of our risks. And actually, when you look at the place escalated risks as well, because workforce is going to be key to delivering our urgent care challenges, maternity, mental health, LD and autism, and industrial action just overlays an extra lot of challenge around that. So I met with the place on provider chief nurses on Monday. Workforce is a really key part of our focus across the whole system. So not just in health, but actually how do we support the care sector, and working really closely with Christine and people around the one workforce approach, and what does that really mean for us in South Yorkshire. They were just the key areas I was going to pick up.
Thank you. So the ones I'd like to raise for the board are covered in a brief update and urgency minutes. Yeah, we've already referenced that earlier today, and I would argue this is our single biggest risk in the system at the moment. And unfortunately, delays in handover of ambulance for patients in ambulances in our accident emergency departments does mean there are people in the community who aren't receiving that timely care. We're working with our local ambulance service alongside the other two integrated care boards that we share our ambulance service with, and we're looking at that harm that's affected. So we're in the early stages of really understanding what the impact of that is. But that's why I draw that to our attention. We have received a letter in September about planning for winter. We've had a subsequent letter that's landed in the last couple of weeks called Going Further on Our Winter Resilience Plan. We're working through that to benchmark about where we're at our starting point and where we need to get to. That's overseen by the Urgent Emergency Care Delivery Board, which meets on a monthly basis, and I'm executive lead for that. Richard Jenkins is the chair of that. So there's a huge amount of work and focus being undertaken on this area. Another part is at the other end of the pathway, because the ambulance turnover delays are a symptom of a system that's stretched from end to end within the pathway. But particularly discharges have been a focus, because it is reported that there are patients who are in hospital who could potentially be discharged, but because of support and other services they may require are prevented from doing that. So we had a 100-day discharge letter. It seems to be have lots and lots of programs that we follow through. So that is another area that we've identified on our risk assessment. Some specific actions that have been undertaken regarding the trust with our greatest challenges is, I know Sheffield had the quality improvement rapid programme of improvement work that was undertaken at the beginning of October, and that 30, 60, 90-day plan will be followed through for hopefully some wins that could be undertaken quite quickly. And I know, Richard, you've committed in Doncaster to have that to be undertaken. We think the week of the 14th that will be undertaken as well. It has made a significant improvement in other trusts that have undertaken this work. So I think that's one piece of work alongside a host of others that we'll be looking at. There are 5 supplementary documents which have asked us to focus on particularly, and this I'll just finish on these. Ensuring that we've got a community falls response. So those people who are fortunate to have fallen at home or in a care home, how are they responded to without necessarily being taken to hospital as the default? Adult and children respiratory infection hubs, thinking about that we come to winter and we get more flu, coughs and colds. Third one is care home ambulance conveyance, and that links into our primary care enhanced services, where we have dedicated PCNs aligned to care homes, so we can have a bit more of a responsive, proactive approach to planning for what actions we might need to take. The next one is supporting people who have attended A&E on a number of occasions, and once again being a bit more proactive about what is it that they need that we can maybe provide in a different way. And finally, on the 1st of December, there's a proposal that we have a system control centre that has a bit more oversight of the day-to-day pressures that are in all of our system. And I know Jo is working heavily on this, and I'm trying to support her to come up with a system that will work for us and also allow us to manage escalations. So I think that's probably the bits I wanted to highlight in the report, but happy to take any questions.
Thank you. Thanks, Gavin. Any questions on that before we go on to the next bit of the operation? I guess the real feel, and it comes through both the locality reports on this, is the pressure around emergency care. It just feels one endless. And your point that it felt like that all over summer and now we're in winter. We've still got COVID and the flu. Really does look as though it's giving us real trouble to the community. My fear is that. Damien and then Lisa.
Yeah, I particularly welcome the system control centre oversight for the 4 areas. I think we need to recognise that composition of each 4 systems is different. Yeah. But also picking up on Emma's point earlier, the end-to-end flow and having a greater visibility and understanding of that system dynamics flow, I think would be helpful at whole system level. I don't know what capacity we've got or design capability that we've got that's invested in that, but it feels to me that if it's happening in Sheffield, it really ought to be a scaled sort of response with the capacity to support each of the areas within a wider plan, if that's where we're going, the idea around central control system.
I agree. I think that the real fear, is that what we have traditionally done in the NHS is looked at flow from an acute hospital perspective, which says, let's look at delayed discharges. And they're a problem. Actually, I always look at it if it was my late mother or something. If she was 85 in a nursing home, I don't want to take her into A&E. I actually want support in the nursing home. And I think we suck too many people into A&E. And then you get all the problems that you've got. And so the flow from the community really does need to be looked at. We need more, I'm almost certain we need more support in the community. And that might not get us through, to help us through this winter. My God, we should start looking at it. And I think the work in Sheffield, we should look at it and then look at all the other places, Dave. What did we learn? I've got Lisa, then I've got Lisa.
I think my point is regarding the mental health, learning disability and autism section of the report. I think the thing that stood out for me was that the demand for IAPT was quite low, given the problems that we're having with people's mental health. And I know that you're working on targeting specific communities. I know lots of people don't engage with IAPT because they're not relatable. The typical IAPT worker is maybe a young, white, middle-class woman. So lots of men don't engage, lots of people from UK minority ethnic groups don't engage with it either. And I guess I just wanted to know what you're doing to improve the representation in IAPT or with the service so that we can increase use, really.
It's a really good point, because given what we've all described around mental health clubs, to see one of our low-level mental health interventions poorly used feels wrong, doesn't it?
Mark, what do you want to come in terms of some thoughts we've got on that?
Yeah, I think IAPT just typically I think access does tend to fluctuate between groups. What is happening at the moment nationally, there's a view to actually basically rebrand IAPT, which actually will take on board actually the very point raised about access, because it clearly doesn't. It's not as well accessed by different groups. I think you're absolutely right, Lisa. So I think there are local initiatives in the individual organisation about how we can improve access into communities. I think nationally they are looking at the full rebrand of the IAPT.
We talk about using community groups and working with community groups, and I know a lot of community groups have counsellors, so I think working in partnership with them, we could really increase.
Absolutely, absolutely.
Really good point.
And I think the point again, primary care perspective, when we look at in Barnsley, we have an alliance with our Barnsley primary care network, and I think the understanding between what we see in primary care and what's provided by IAPT, which is improved access to psychological therapies.
Thank you.
I think that there needs to be a better linkage and time between the providers as well to actually really understand consistency of the message.
really important point. Leslie?
I was going to go back to what you were saying, Piers, really. So in terms of whole system, and if, you know, we do tend to focus on what happens in acute trusts, and actually, I'm not seeing a lot of information about what's happening, for example, with 111, where we're trying to get people actually to avoid going there inappropriately, and giving them the right sort of help in another way. So I think, you know, that for me, I've just not seen that at the minute.
So I guess it's not to say it isn't happening.
No, no.
I know, because we're working, that's part of the discussions we have, because our ambulance service not only provide 999, they provide 111. So we're working as a group. In fact, there's a winter communication plan that Andy and his team are hopefully launching soon in regards to 111. So I think that does connect to the work that's been undertaken, but maybe it's just not cited. So we'll make sure that's shared.
I mean, I think that I once did some work with ASDA, which sounds ridiculous, and they talked about you are what you measure. So if we only measure acute throughput, that's all we'll talk about. And it's a really important point that says we know the emergency care is about a whole pathway for providing support to the community right to, as you said, palliative care. Actually, it might take us some months, but I'd like to see a report that reflected that. What is happening in demand all over the place. So really interesting that IAPS, we're talking about mental health demand, that IAPS is underused. That's the kind of stuff we need to see at this, particularly at this level.
Can I just I think also it's about, it is what we measure, because what I noticed was the number of calls dropped on 111. What I didn't see was the wait times on 111. So if somebody's been waiting for 7 hours for a call back on 111, they're turning up at A&E. They're not waiting because they're anxious. So it's understanding where the pressures are in that wider system.
Yeah, thanks, Jay. So this returns really to the sort of principles that David was talking about the system and the regional responses. And recently, the acute trust had a system response to ambulance pressures, which was basically that the ambulances were allowed to attend any A&E depending on the pressures that they were in the system at the time. That was designed to release the ambulances. But what we ended up with then was the law of unintended consequence, in that most of the patients who arrived needed admission. Once they were admitted to a hospital and their discharge postcode was different, what that did was extend the length of stay in hospital. The discharge pathways became much more complex. And we then ended up with more pressure in the system because the bed occupancy went up. So I know we won't do this, and David's already talked about it, about making sure that we coordinate the end-to-end process, so that actually what we get at the end of that is reduced wait for ambulances and responses in the community, not further pressures as a result of that. I think what we then also need to recognise is that one of the things that we've had in South Yorkshire recently that's caused about our COVID numbers, which were very high nationally. I think in my patch we had 11th and 14th highest COVID infection rates in the country, which put huge pressure on the beds. And we've already touched on the challenges we've seen in the last 3 winters is that where we've had improved infection prevention and control measures of hands, face ventilation, combined with the vaccination programs, what we've seen is lower levels of COVID, lower levels of influenza, and low levels of norovirus. And actually all of those 3 things are really winter pressures. So what I think we do need in a public meeting like this is just to ask our public for support in terms of we're facing an unusual event in this winter, in that we've got a World Cup in winter inside. And obviously my football supporting head would say I really want England to go all the way and win. My health related head said I don't want too many people who might have COVID mixed in public. So I think it's about the messaging in terms of if our communities can really get behind the vaccination programme where that Anthony's talked on, get vaccinated for influenza and COVID, and just take sensible precautions, not attending events if they're not feeling well, and obviously making sure that we do hand spacing in any time we gather over this cold winter period. I'm absolutely sure it will help us as a health service, primary and acute care, get through in a lot better shape than potentially would do if we don't do those sorts of sensible things. So those points.
Really good point, Richard. Thank you. David.
Just a final point then. I think what we've raised today is the complexity of it and how it interconnects across a number of different programs. It sits with the UEC board, but it connects into mental health, it connects into primary care, it connects into health inequalities. So to make that, and also, you know, obviously we're focusing on what things that aren't going well. There's lots of good practice going on, and actually we are learning from each other to disseminate that across the 4 places.
Really helpful. Thank you.
I just had a couple of quick comments there. So I think take Leslie's point about we need to make the information more useful end to end. I think some of the trends as well, the kind of dashboards, but it's really hard to interpret. So I think it's a piece of work for myself, Joe, Kieran, probably just about how do we do that better. I think just picking up on Richard's point about the, you know, when we focus on ambulance handovers, the interface at A&E, that's really a symptom of a wider cause. And I think, you know, as we move our thinking forward to the strategy, I think, you know, we clearly need to deal with the immediate challenges, but we need to be thinking about, well, what's driving the demand? How do we anticipate, you know, deterioration? How do we intervene early? How do we avoid the admission to hospital? Which, to be frank, you know, if you're frail and elderly, admission to hospital is probably, you know, one of the worst things that can happen to you. It's not a risk-free kind of endeavour. The final point I want to pick up, which is part of that notion of getting upstream, and I think Lisa described it well. I think in the context of mental health and, you know, kind of IAPT, and how do we maybe upskill communities, community groups, etc., to support kind of underserved groups within our South Yorkshire. So mental health is one area, but actually you could apply similar approaches for long-term conditions, you know, whether that's diabetes or COPD or cardiovascular disease. I just think it's a really important concept that we ought to come back to as we develop our strategy. Sorry, that was it for me. Joe, do you want to give us some headlines on operational delivery? I think we've done UEC, but maybe on planned care.
Yeah, on planned care, UEC, I think so. There's one thing that I'd like to make on discharge. So around discharge, we got about 5.9 million from national teams. We've got increasing beds across the patch, and they're not necessarily physical beds, bed equivalents. And we, in the report, says we were past 74 out of 139. We're now at 84, so we're pretty confident that we're going to get to the 139 by the 1st of December, which is positive. In terms of recovery, our letters in cancer backlogs aren't where they need to be, and I think we recognise that at this patch. The event that I also attended last week with Piers and Gavin was very clear about the fact that we need to improve that position. It's not fair to have patients waiting. And I think what we just need to look at in a bit more detail is the waiting list is mainly made up of non-admitted patients, so it doesn't really impact on winter. So it's how we work out, how do we see those patients in a timely fashion in order to get that waiting list down. It's not about beating a target, it's definitely about seeing patients at the right time. And I know we might get some conversions from those waiting from outpatients, but we can deal with that if we can just get into a position where we're seeing patients sooner. In terms of cancer, Sheffield is the area where we've got the biggest backlog, and it's growing, unfortunately. And NHS are offering some additional support to Sheffield around cancer backlog and also around their elective programme. So that work starts. I think that's all I want to flag, really.
Thanks, Joe. And then we've got Chris on workforce and Lee on finance.
I'm sorry, Kevin.
Thank you. Just on planned care, can I just pass an observation about the report itself? I mean, I'd echo the need to really continue to improve it. I found myself, I love numbers, and I found myself drowning in an ocean of data, sort of missing the point.
Yeah.
So maybe a take home is less is more, and maybe a little more focus on what's happening to correct the problem, and maybe some read across. And I wouldn't want the place report to performance management things, but maybe some read across what's happening in their place tackle some of these issues. That's just an observation. I think the question is that on 104-week wait. I think at our last formal board meeting, I think we were pretty optimistic about achieving the target at the end of September. And what we've got here, particularly in Sheffield, I think is quite a significant miss. of that. And I know the report cites critical care, but what has, just keen to understand what has really changed over the past 2 months on something that essentially we let 36 people down.
Maybe I could pick that up. I think if we gave that impression in the last meeting, I think that was incorrect. I think we
stand correct.
So, no, I may have kind of given a kind of a sense of optimism. I think we know there's a challenge at SDH, particularly around complex spinal cases who are waiting for planned. It's not time critical. It's really important to those individuals, and they're waiting for planned surgery. The difficulty is, I think Joe was talking about cancer backlogs at SDH, because these cases are complex and require critical care. There's a balancing between, to be frank, who gets access to the critical care beds, and quite appropriately, SDH are prioritising the time critical cancer patients over and above these complex spinal cases, and that's not an easy problem to resolve. So we knew about that last time. In fact, to be frank, the trajectory that SDH provided has actually is deteriorated. So they were planning 30 to 40 at this point. They think that will grow over the winter as demand on critical care increases. They are working with, they're reaching out to all sorts of organisations that provide this sort of surgery across the country. But the difficulty is that quite a number of the patients waiting don't want to move. They're prepared to wait and want to wait and receive treatments in Sheffield. And clearly that means, we're not able to manage them within 104 weeks. So it's a complex and difficult problem. It isn't, I don't think it's a quick fix, Kevin, to be frank.
It will be really quick. I think it's really something that's really important is that we don't just get focused on the numbers and the weights and actually what that means for that individual that's in that waiting list. One of the things we talked about at the ICB on Friday was how we help people live well with illness, which I think is really important, because if you're that individual waiting for cancer surgery and that's your only option, and you're in a backlog, mental health starts to deteriorate, your anxiety starts to deteriorate, and how we make sure that we thread that through the conversations that we have and keep the citizen as our focus around those discussions, I think it's really important.
I agree, we can talk about numbers, these are people easy to forget that at this level sometimes. Point well made, Catherine.
Christine, do you want any escalations to the board around people on the work?
I mean, clearly workforce has been mentioned throughout most of the reports. The data that we're showing in here is the month 4 report that the region provides us, and we are working with Kieran and others to try and make sure that we get an extrapolated South Yorkshire position. And as I mentioned at the board previously, it's tracking behind the financial data. So, to try and provide a sort of triangulated position against sort of activity, finance and workforce is quite challenging from a data position at the moment, but we are actively working on that. So the report does show pressures across South Yorkshire, particularly in respect of retention and absence, and obviously higher agency spend. We do have plans in place to try and manage the agency usage, and we are developing a number of collaborative banks across South Yorkshire, and in particular a new collaborative bank around admin and clerical roles, because that's a particular pressure at the moment in some of the acute trusts particularly. We do, in terms of retention, the latest information coming out is that we are actually performing quite well against other organisations in South Yorkshire. The caveat to that is we're all off plan. So, whilst it's good, we're still not on plan, and we're above our planned agency usage in that respect. We do have a very comprehensive health and wellbeing package that is available to our one workforce. That's health, social care, volunteers, students, and various other things, which is fantastic and designed to support our colleagues stay well and stay in work. So that's really important. I think it's not in the paper, but I think it would be remiss of me not to mention the planned industrial action, which will, I know is in Gavin's chief executive report. Just to re-emphasise, this is a national dispute. Ballot papers are out at the moment. We're anticipating industrial action at some point between December and into next year. Our responsibility as an ICB is to coordinate across our organisations in South Yorkshire so that we get consistent approaches and maintain our good partnership working and relationships with our local trade unions. To emphasise, this is a national dispute. There is not a local dispute with our local trade unions, and so we need to maintain those relationships. And this has been also handled as an emergency planning exercise, so there was quite a lot of information coming through the emergency planning route and some quite rigorous testing and planning of the system. And I just wanted to finish out, and obviously workforce is a big issue. What we are trying to do is multi-year workforce modelling. So we're trying to move into a more proactive space. We're also working alongside NHS England and Health Education England to look at 15-year strategy. So the really long framework 15 is the really long-term workforce strategy that you'll hear talked about in the news a lot. You know, we talked about our long-term workforce, and we are having conversations and inputting into that process as well. So we are working on a more longer-term picture, but clearly the pressures are immediate and challenging.
Big questions, Christine.
I know that we're exploring this, but it would be really great to see more social care dynamics, I think, in a workforce report. It feels quite health orientated when we've got quite a bit of codependency there. And I know that Zoe Thomas from Skills for Care is connected into that to start to think about how we might do that.
The other thing I'd say is someone who's worked in the NHS rather longer than I'd care to own up to hear about us having problems having used agency for admin and clerical feels extraordinary. And what that is about, I think, is that, you know, admin and clerical jobs just feel like jobs that don't go anywhere. And people can earn far more in, I don't know, Amazon, who've opened up recently. They're going to go. And for someone who used to work, the idea that we can't recruit admin and clerical people genuinely feels extraordinary. But everywhere I go, people are telling me that's real. And, you know, it's about broader economic issues there. And I was talking to Sheffield Teaching where they were talking about their waiting list validation is undermined because they haven't got staff to do it, which feels quite extraordinary to me, someone who worked in the NHS for many years. But that's clearly real.
It builds on your point, really, Chair, in that we are where we are, and obviously the workforce is one of the key issues in all groups now for the reasons we just touched on. But I think what we did see during the pandemic, and what we can build on is that we were much quicker to adapt and to change and to apply technology.
Yeah.
And I think we have an opportunity as a system to think about how we want to provide services in the future around things like digital enablement and artificial intelligence, as well as workforce, because if we are able to move to APRs that are actually interoperable or in, you know, the same one, what that does is it gives you a huge workforce flexibility then on things like admin and clerical and or validation. Using the same system, and the same system gets to be the system that anybody in South Yorkshire can use, which basically means you can be flexible about the work. And actually some of them are also clinical issues about risk management, because what we know from junior doctors or others who rotate around is if they go to 5 trusts and have to do 5 different things in, you know, to do and achieve the same result, it's 5 sets of training and it's also 5 sets of risks. So I think as a system, we've got to sort of think about all those things together, because there are some huge opportunities in there, I think, that, you know, we could get to fairly quickly with some of them that actually will help with some of the pressures. You know, including things we've talked about patient choice and movement. You know, if notes move fluidly and freely without obstacle opposed to others, all of those tasks become much easier. So I think it is about us thinking more laterally about what we are in control of and what we've learned in the pandemic, as well as directions to travel on.
Workforce. It's really cool.
Thanks. Lee, finance.
Just 4 things to note from me, not escalate particularly to note. This is still a very NHS-centric report, so it shows the financial position for the ICB and the statutory NHS providers that we hold. I'm having a series of conversations with the 4 Section 151 officers about how to start to incorporate some of the sort of social care spending information in there, which is going to be really important, I think, for planning for next year. If we look into the financial settlement for next year, it's going to be really important we understand the local government position around adult social care alongside the NHS position. Those conversations are ongoing. So just touching on that first, it's a very NHS-centric report. point to, we've got a deficit in the NHS family at the moment. Sounds like a lot of money, 11.7 million, but it is on a sort of baseline of 4.8 billion across the whole of the NHS spend for all of our hosting providers and the ICB spend. So 11.7 million, I don't know what it looked like in tenders in a shed, but quite a lot of them. But as a proportion, it's not an enormous amount. But we're looking at how we can deliver as good a financial results as we can by the year end, noting the operational quality and workforce pressures that we've got. I think the whole of the NHS budget is under pressure for the reasons that we've cited. We are throwing the kitchen sink at unscheduled care. We're trying our level best on elective recovery. Where the messaging sits on that about the relative priority for finance at the moment, I would claim we're not entirely clear on some of that, about the absolute imperatives around financial balance versus those broader imperatives. So that's the third point, really, about we're doing that work on year end. The fourth point then is just a big piece of work about underlying financial prognosis for 23-24. I was locked in this room with my director of finance colleagues from providers and my CFOs at place level, talking about how do we start to bolt together that underlying position ready for next year. And there are some exploratory conversations about how do we try and get better alignment through operational planning, workforce planning, do this once and well. And perhaps that's one of the opportunities afforded to us in ICB. So to notice a bit NHS centric, we have got a deficit, proportionally not bad as all that. Third point, we're doing as well as we can by year end, noting the pressures we've talked about. Fourth point, just the work that's starting about what's the underlying position for 23-24. Thank you.
People want anything? I thought it was interesting there. Kieran and then Ben. Kieran.
So thanks, Chair. Just a very quick one on the comments on the report. I think it's just to provide a bit of assurance that work has already started and is ongoing to improve the quality. We want a really strong IPR for South Yorkshire. Presentation of the insight is incredibly key and will be designed and totally refreshed with users in mind. We want to provide that richer integrated insight by bringing that statistics together that triangulate quality, workforce performance, etc., with really good visualizations, trend analysis, and dare I say even forecasting. And just touching on a point that was mentioned earlier, we want to design it so that it's as accessible as possible, following the gov.uk and NHS service manual, so that the insight and essentially the bottom line in that report is accessible to everyone. So just a point there, Chair.
Really helpful, and I think but it is really important. Ben.
Yeah, just a general comment, I guess, on all of the performance stuff we've discussed. I think all of it's important, but how much of it connects back to those core ambitions around improving health and tackling inequalities in the sort of statement that we've put as an ICB. And I guess that challenge to us as a board around how do we get things into this report, because as Piers said earlier, sort of what we measure is what we do. So we are measuring things that are actually about achieving those ambitions and wider at what we do and how we do that. And I guess one of the comments, just linking back to the question we had earlier around having an equalities assessment against board reports, actually we need something bigger around some integrated impact assessment that looks at what's the impact of this work on health inequalities, on prevention, on some of those ambitions. Really happy to be part of any group to develop that, and I guess it's part of the ICP planning and the work to get the next iteration.
I agree. I think the biggest challenge the ICB faces for the next 2 years is we will be under huge national pressure to deliver numbers, the kind of numbers we've just spoken about. Ambulance waiting time, GP access, cancer rates. By the way, we've already said the real people waiting those numbers. It's not and there's a health inequality aspect of that. The challenge for particularly the ICBs, the NHS in general, particularly ICBs, is we will not get the freedom to act on health inequality if we don't deliver the numbers. Whenever we think about that, that's the real world that, no offence, Gavin and I are inhabiting when we get phone calls from Secretary of State, for instance. So we've got to do as well as we can on those numbers to make a real difference around the health inequalities. It's not an either or, because we will not get the freedom to act if we don't hit some of that. But one of the real challenges here is to do the numbers in a different way. we've already talked about, we only look at discharges and admissions. We probably won't hit the numbers, but actually won't hit health and equality issues, which is reaching out into communities in a different way to provide support. And I think the board, one of the things the board needs to do, to me and to Gavin, is keep challenging us on that. Because it's real. And what I don't want to do is say to you, don't worry about the numbers, because it's real. But actually, how we deliver those numbers over the next 2 years is the only way we're going to get the health and equality issue as well. That's the challenge for us. David.
Yeah, I mean, absolutely. I think we're slightly in an impossible task, aren't we? Let's be honest. Then that has been the case for a number of years, and obviously the Chancellor and indeed presumably the Secretary of State identifying that actually, whilst there are no cuts, they're expecting efficiencies. I think we can probably understand the rhetoric that covers. Yeah. But the reality is, I think, in terms of the context of the IPR, is there is a discrete difference between efficiency, effectiveness, efficacy, and impact. I mean, it struck me in Chris's report at the start. I mean, I don't know what the resource was to sort of produce the video, but actually there was a really efficacious and impactful intervention in terms of reduction in suicide rates. And, you know, whilst we need to look at the costs of operations and reduce those in terms of some of the process improvements, we also need to be clear about the efficacy of interventions. And, you know, the NHS has a predilection for pathways. That's quotable, I think. You know, but that doesn't necessarily bring about efficacy or impact. Yeah. And I think it's important for us, if we're going to be cleverer, to understand the distinction between those 4 elements in terms of activity, performance, and impact. The, you know, the sort of 3 A's and 1 I.
That's really important. You're welcome, Coruscant.
Yeah, there's one thing, because we've talked about Ireland. I think the way in which we're engaging with both public and clinicians, targets don't ever really get much traction. In standards do, or quality goals, or outcome goals. And actually, what patient wants, wherever they are, you know, and we see it all the time, is if you go to the patient point, I don't think patients are worried about how long they stay. Is when they're there, is something positive happening to them, and as quick as it can be. So I much rather, I'd say, in my own organisation, talk about, are we achieving the standards we need and want to achieve, rather than are we achieving the targets? Because those targets are just about quality service. Whether it was 95% A&E, that was a quality standard. That was about not spending too long in A&E and not spending any unnecessary time in A&E waiting for something that isn't happening. So I think we can do a little bit of that as well. Efficacy and outcome becomes part of the reason we're doing it. We're not doing it to target. What we're doing it is the services we provide, whether that's cancer or discharge from hospital or whatever it is. It's about making sure you move to the next step of the point you're into.
Really helpful. Lee, thank you for your point. No more points, so moved on to corporate insurance support. Mark, is this you?
Yeah. And a number of points I just wanted to tease out of the report. But before I do, I just wanted to just take an action reflecting on Mr. Wright's question, just to reframe this report, to make it clearer and more meaningful, I think, both towards the board, but also for the public. Given that it's a relatively dry subject.
You never describe your report as dry, Mark.
There you go. Thank you, Chair. I was entirely looking for
That was fishing, that was.
Okay, there are 3 items that I do particularly want to tease out. The first is just to highlight the ongoing work around the development of our board assurance framework and risk register. We're continuing to work to develop that. We have the development report, which is reported in the report. In October, we've got a draft framework. We're going to explore and test this out with our operational executive on next Friday. Lee and I have a conversation this week as well to test out and the framing around the board assurance framework, the risk register, and the interaction with a number of other elements of our corporate life. And we do also have a staging point in an audit and risk committee towards the end of November where we can test progress too. So that's, I wanted to highlight that around the bathroom risk register. The next item, and I think it's important to just tease out because of our duties as an employer of 900 staff across multiple sites. Our health and safety group met for its first inaugural meeting. So that's reported within the report. And then finally, a really significant duty that the ICB carries under both the Health Act and the Civil Contingencies Act of 2004 is to ensure effective response to emergency situations and incidents. And I can introduce and ask Will Cleaver-Gravy as our accountable emergency officer. Would want to say anything about the core standard self-assessment that we're running through at the moment.
So I think what we just wanted to draw to broad attention is actually where we've got to in terms of ensuring that our people are adequately trained to respond in an emergency. As part of the assurance process that this organisation, this board will have to undertake is self-assessing itself against a set of core standards. Quite critical to those core standards are that our people are engaged in on-call arrangements, are able to respond appropriately. So you'll see within the board report, we've pulled out for you the training standards that our on-call staff board have taken. So, and just to highlight that really clearly, they all meet the basic core standard. So when that comes to our board in public next month, as it will, in terms of our assurance process, you'll have seen that. And you'll remember that back in September, we asked the board's commission to be able to do that self-assessment and submit it in lieu of the board.
That's it. In terms of coverage, Joe.
Any questions on that, Mark? Thank you. Strategy and development, population health and health inequality. You know, Barbara's just joined us.
It's behind you.
Oh, yeah. Don't do that, Barbara. I thought I saw you walk in. No, that's what it felt like.
So Piers, I'm going to introduce Barbara in a second. I suppose this is the third paper that we've brought to the board on our developing population health and health inequalities, approach. So I'm not going to steal what Barbara's thunder actually. I'm just going to let her do a brief introduction. We've got two papers today, so Barbara's going to take us through the first one and just pull some highlights out, and hopefully we'll have a chance to have some discussion, and then I'll pick up the second paper on cancer. Okay. On that. So Barbara, brilliant.
I think I'll stand up. That's all right, because it's a big room. So firstly, thank you all for accepting my paper. The report was written to inform the integrated care strategy that we are writing with our ICP partners. And if you read it, it is 30 pages, so I'm not going to test you all, but if you have read it, you'll realise it is a bit of a sombering read. But that was my initial purpose, was really to set out the challenges that we have as a system, and then to help us galvanise our action around that at an ICP level, at an ICS level, about how we can actually come together on those issues. Because health isn't about our behaviours or all the services we receive, it's about the environments and the communities where we live. So I really wanted to make sure we had a holistic view of what health is and our health outcomes and the drivers for our health outcomes. So we've gone to the paper that you've got, and also a slide deck has been presented to the ICP board, and it is being used to drive the priorities for the ICS. And we're going to be talking a little bit about the strategy and how that's further in developing. But just so you know, that's how it all kind of come together. So we did this narrative to inform that strategy. In terms of next steps, we have set up an intelligence community, and this includes people, analysts from our trust, BI teams, our ICB, local authorities, fire and police and the MCA, and we together, the community, are coming together to create a South Yorkshire health profile. And that will be something that will be publicly available and something to engage our partners, our community and our public with the health outcomes for the whole of South Yorkshire. It was also my intention to do a South Yorkshire report, because there are already place reports in JSNAs, and I didn't want to duplicate those, but I wanted to create something that gave us that whole view for South Yorkshire. So this group, we're called the DAISY, by the way, which is Data Analysis and Intelligence for South Yorkshire. We meet every month and we're going to have collaboration and lots of projects where we come together to make sure that we are all using and harnessing the power of intelligence to drive improvements in our healthcare in all the organisations that are represented there. So I've got lots of high hopes for that group. So there will be a public version of this narrative that you've got, and that will be developed over time and will grow. So brought the paper for you today, basically just to note it and to recognise that it's been used to inform the strategy, but also I'd quite like your support to mobilise this across the ICB at least, to make sure all our staff get a chance to read it and have a full understanding of the whole health issues of our population, and maybe not just the bits that they're involved with, not just mental health, not just cancer, but provide a holistic view for our staff. So,
Barbara, thank you. And this was presented, as I was at the ICB last week, was it last week?
I think the last meeting, the 23rd.
Yeah, okay. Life goes so quickly.
It was, yeah.
And it was really well received, really. Leslie.
Can I just say thank you very much for this, because I did read all 30 pages. I'm not sure I've, absorbed it all. I just thought it was a really helpful, really useful summary, splatting it down on a page where we can see the whole thing. So thank you. That's my first thing. I just had a point really about digital exclusion, because one of the things that, unless I've missed it when I was reading, I didn't see anything in there. We talk a lot about digital, and we talked about IACT earlier. There's lots of things where we're pushing people to use digital platforms to do things, but actually we know that could encourage people properly, but equally for some people, that's going to add to their exclusion and their health inequality and the outcomes that they're going to get. And we haven't got anything in here that reflects what the digital picture is in South Yorkshire, and I just felt, particularly when we look at certain groups, both geographically, age-wise, and from a point of view of economic power to buy those kinds of things, it's becoming increasingly important. And I noted when we move on to the, that Lou's presenting, we're talking about movement towards more digital, but we're not actually saying, are we going to make the situation worse?
A great point. I think there's one stat in there, and I think it's something like 12% of people are digitally excluded at the moment, and it's greater in people of older ages. But we do have, and I can't remember who now, but there has been a report commissioned around.
Doncaster.
Yeah. So I have contacted the leads of that, and I'm trying to bring in some of their data and insights.
I think it's useful at the level as well.
It's a really important point, I think, Barbara, isn't it, that increasingly to get more efficient, we want to rely on digital. We've got to make sure that doesn't exclude communities. I think it's
Chair, just to come in on that. So yeah, a report has been done. I think 37 focus groups were assessed across South Yorkshire. And there were a few key findings on digital inclusion, things like access to internet, access to Wi-Fi and devices, and actual support in using those digital tools have been identified as key things. And I think that report's basically a foundational piece of work that will allow us then at place to work with our places and partners to review and improve digital inclusion.
Thanks, Leslie. Point. Lee, you want to say something?
I think it's a great report. Thank you. We're going to have a real challenge, aren't we, for 23-24, which I oversimplify as we're going to have incumbent costs in the NHS system, which, unless something mystical happens around the Chancellor's announcement for 23-24, may or may not be met by the allocation that we receive as an NHS authority. And we're going to be behoved to think through very sensibly, how do we intervene differently around population health and unmet need, which in a population with 37% living in the poorest bit, there's going to be a huge challenge there. I think what I'd be really interested in is how we elevate our thinking to think through, if we have got that typical population in South Yorkshire, because it is not the national average, is it? 37% in the poorest bit. What might we expect our programme spend to look like to maximise health outcomes? Because it would be a different profile of spend, than the national average. We'd be intervening in a different way upstream. We'd be doing community engagement in a different way. We'd be prioritising it more. And I think it might be a good way to be challenging us as a board about how do we set our financial plan and workforce plan for next year, because we should look atypical in terms of the things we're targeting because of that atypical population.
I absolutely agree with that. We should not look the same as somewhere else because we have a different population. Emma?
I think building on that, the amount of work that the BCSC and grassroots communities are doing to actually prevent demand is unbelievable. It's not measured anywhere, is it? So it'd be interesting to understand how we measure that, but also as an ICB moving forward, will we be able to protect percentage? Into that and make a statement about that in terms of actually, we need to treat the large sector as a partner, not as they're trying to, well, we might do some money next year, we're not quite sure how much. And again, I know we've got all the pressures around keep, and look at that, but actually, we're moving towards that to show our ambition really to invest in that sector. I guess, and also that sector's worn out, they're absolutely burnt out. And the takeaway message for me yesterday was, we are all burnt out, we are working 18 hours a day, working Saturday and Sunday, some volunteers, just to manage and help people navigate through really complicated housing benefits, health, children. There's loads of issues, and again, we don't measure that at all, do we, in terms of our spend? So I just think, I'm not sure what the answer is, but I think making statements about potentially protecting more resource, point to prevention, and thinking about how we measure and quantify activities, I think we really.
Cassie, and then Jamie.
Well, I find it really fascinating. It's what actually something just nice on Friday that I used at a time out with the chief nurses across the system on Monday, and it was a real eye-opener to them because they just don't see this sort of information, all the challenges that they've got outside of their operational walls, and there was a real plea for them to be engaged and embedded in the workplace and outside the hospital actually. But some of the things that they described were how we utilise and support the voluntary workforce better as a key part of our workforce, but also how we support individuals with better lives within risk, and live better with ill health, to help us on this journey. So I think it's really important information to share. And I had a conversation with a community matron yesterday actually who's focused on kind of respiratory and some of the working in Rotherham, and again they were sort of unsighted on some of this and how do they link, if you've got multiple comorbidities, you link in with different specialists and different community matrons who deal with one part of you, and there's a lot of work we can do to really support our communities to manage this better.
Yeah, it was more around, having been in a national voluntary sector organisation for years and understanding local, small, in some cases micro organisations. The biggest thing we could do is to create a degree more certainty over time, and look at the buying power of local authorities and the NHS. It's not beyond the wit building that resilience at place level to create a proper commissioning and grant giving framework. Mindful that that's not back to the sort of hard to reach, difficult to ignore, or not necessarily even trying, is that we do need to respect the independence and the autonomy, but at the same time, we do waste a lot of transactional effort, time and resource in trying to engage and commit that capacity. Obviously, there's a certain amount of veracity about efficacy and things, but at the moment, it feels to me, come back to the knackered comments, that actually everyone is, in fact, it's the new norm. But the reality is that I think if we're looking at asset-based community development, looking at health inequalities, it starts with that level, and we just haven't systematised the processes. And I don't mean that in a way to disempower the agency, but we could do so much more in each of the 4 areas and across the whole piece to create greater resilience, I think, in the system. And that is usually when you're looking at core costs in things. So that would be my plea if we're looking at a time frame for that. It's a little bit like the challenges that you posed around this year's budget, next year's budget, really.
You're right. When I did some work with the voluntary sector, when I first started just talking, they said give us more certainty. We don't live us hand to mouth every year. We don't know what we're doing. And actually, it's a small thing for us, probably because these sums of money aren't big, often massive issue for them. What do you think?
We've said we know that we've got many thousands of voluntary sector organisations across our South Yorkshire patch, and those organisations deliver work and support at a grassroots and community level, and lots of colleagues around the table have articulated that over months of years. I think what I'd like to do is in the background, as we're developing South Yorkshire Voluntary Sector Alliance, it isn't to take away from the work that's currently happening, but from a voluntary sector perspective, present and communicate with the board and wider partners in terms of the priorities of the sector and what we think needs to happen at the different levels. So, for example, in terms of even the primary care network level, not every voluntary sector organisation is fully visible to those who needs to be visible. So in some areas, we're not clear where groups are, what they provide, who they support, how people access that. We in terms of clinical pathways, there are particular clinical pathways where it would make sense for one sector organisation to work alongside those clinicians to look at community pathways. So I think what I'm not articulating very clearly is I think we need a strategy where the voluntary sector is concerned as an ICB to be able to look at the complexity and the whole voluntary sector ecosystem to see where it is that the interface and the ability to work better collectively can be. And that's what I'd like to get to. You know, we're developing an alliance. There's lots of priorities, but within those priorities, we need to decide on what we're going to do when.
That's really important. Let's not lose sight of that. I've picked that up with you outside. Mark, thank you.
Question for Barbara, actually. I think echoing everything that's been said, there's some really fantastic information here. Clearly, the environment we use is going to be high as well. The creation of an intelligence community seems an absolutely logical step. Are you convinced about that's got the right level of capacity and I guess skills to be able to do what we're needed to do in the coming years?
I think I've been an analyst for 20 years, so I'll always say invest in more analysts. But we also need to shift, and there's a huge piece of work we need to do about shifting the capacity and the skills of those analysts away from the churning data, and we've got hundreds in our system that do that, churn press numbers, into making them analysts that can convince and tell stories with data and sit with the clinicians or sit with groups and help them interpret the data. And so there's definitely a shift we need to do there. I'll always say invest in more intelligence. The people in the DAISY group are excellent analysts and know their stuff inside and out. And we've got really good connections with the DCPH network, for example. So we know we've got that sort of, and the energy's there, the willingness is there. So yeah, we're nearly there. There's an intelligent strategy that needs to be written, and I'm happy to take that on board with the DAISY. To think about the long-term solutions to exactly your question, but yes.
Thanks, Mark. Kevin.
I really just want to echo Shafiq's point, really, because I've been around the NHS for a long time, and only recently in another role have I become exposed to the breadth and in I'm reflecting back on David's 3 E's and I think we would collectively be staggered their impact on the broader determinants of health, because even with David looking for health and care holders, but actually their role in going forward in broader determinants is absolutely essential. I welcome some focus on that.
No, but I think there's something about what we do strategically, as well as making sure it gets picked up a place, and to give back to the place. I think there's something here about certainty of funding. You know, we can't come to them in March with the bit of money we've got left over and say, could you do? Well, that's kind of what we've often done. You know, it just doesn't work. Moira.
Yeah, just on the money bit, one of the things that Lee and I have been talking about is actually getting the BCSE rep on finance investment committee, so that we're actually benefiting from their input as well as, you know, being much more inclusive about how we're actually going to do with money going forward. So I know we were talking to the colleagues about how.
And the Alliance is happy to support that.
Really helpful. Wendy?
To put you on the spot a little bit, Shafiq. To absolutely support your sort of thoughts there about the South Yorkshire BCSE sort of strategy, really, because it feels like it's a bit like a give and get, isn't it? Really, about what space does the BCSE sector wish to head into, and actually what are our priorities, and how do these things coalesce all the time to work together as a community. We could up the game in up our collective game in terms of seeing more lottery funding coming into the patch, which we know is not as strong as it should be. What's your thoughts about that sort of strategic plan there? Have you got some sort of timescales around that?
Not completely in the sense that we know there's lots of things happening at place already where the voluntary sector is concerned. And we know that actually the ICB can't fund 7,000 voluntary sector organisations and groups, and perhaps that isn't the ask. So in my mind, I think we need to make BCS groups visible, supported, and developed at a primary care network level. So, for example, are they visible and appropriate at that level? So I think there's already a lot happening at place. I think what we need to do is amalgamate some of the priorities which make sense across South Yorkshire, that we can support particular neighbourhoods, particular areas where perhaps there's underrepresentation of the BCSE groups, or where we think actually we need to strengthen the BCSE groups. I've got it in my mind that what we need to do is bring the sector along with us, because each of the places, Wendy, are quite different in terms of their engagement, whether BCSE are concerned.
And their fragilities as well, aren't
Yeah.
they?
I've got Chris Edwards and I've got Ben.
Thanks, that'll be great. So just a plea to everyone, the culture we need to embrace when we engage with the volunteers. We've done this over many years, Shafiq. And it's really important that we go with our problems for you to suggest the solutions rather than come up with the solutions ourselves for you to deliver. It's really important that we just don't come up with this is a standard thing across South Yorkshire, please deliver it. We need to have a different way of approaching it.
Yeah, I think thanks to Barbara first for the data pack, because it is brilliant and shows the scale of issues that we've got. And I guess there's something for me about we focus on services as the solutions, and you look at that report and you look at the scale. Services aren't the solutions. It's engagement with communities, and it's culture change within our communities in South Yorkshire, and how we achieve that. And that is through the reach into communities and voluntary sector and those other organisations. And I guess it's we need a good stance from the board at South Yorkshire level, but actually we need to do a lot of this bottom up, and it's about engagement through PCNs and the models we do within our communities, because 7,000 voluntary organisations, the vast majority don't operate across South Yorkshire, they'll operate within a community or within a space, and how we get the right knowledge into the right parts of our system to engage with those and get confidence. I think one of the things I've seen through my career in the NHS, but also through working and supporting various voluntary sector groups, is that confidence of professionals in the voluntary sector is a real barrier to getting the most use out of it. And professionals like to keep people within professional pathways and networks, and actually we need what's the exit from that actually gets people embedded back in their communities and doesn't just say, right, you've had your 12 weeks of service, or you've run through this pathway back home to the conditions and the way you were living before.
I absolutely take on the chin the sort of funding certainty piece, that we've got to think in different ways, as kind of wait until the end of the playing round and go, we've got 2 bob left, give that to lottery. I absolutely take it on the chin. But I think there's a broader role for us really around some of these smaller organisations, and having been honorary treasurer for one of them for a number of years. It's about how do we assist in evaluating impact as well. And I think we're just going to have to be really clear on what are the interventions that can make a difference. And it's really contested and difficult, this stuff, about what is the impact of that. But a lot of those smaller voluntary community social enterprise organisations really struggle with grant applications about evaluating impacts. So there's something about, can we help a bit in that space without patronising?
And for me, that's part of us, not ways of strategy, because as well as making those groups visible and supporting those groups, we also need to understand how we can help those groups develop and grow where that's appropriate. So it's the whole package. It's not just a case of saying there's lots of ECSU groups out there. Let's find a way of referring patients and individuals, because that isn't the answer. We need to ensure that we do that appropriately, safely, and help the sector grow at the same time.
Can I just thank Barbara for the report? I mean, we ended up getting into a real conversation about the voluntary sector, but actually the report's a really important report for this board. I know the ICP valued it, so a really great report. Thank you for the work there. Really helpful.
So, if I could pick up the agenda again. So the way we take this forward is we have the strategic delivery group for pop health management. So I'll take that as the chair there. As we've already mentioned, it will be picked up through the discussions with the strategy. So for that particular paper, thank you, Barbara. I think we can relieve you. But I think the second paper, and I do want to just take a few minutes with that. I've got a few slides to talk us through it. Is how this is in action, how this actually, how we use pop health management and how we, tackle health inequalities in a real sense. So what I'm hoping to do is share. The lung health check program is an example. It came out the long-term plan back in 2019. It was the ambition for earlier diagnosis to shift from 50% of people being diagnosed early to 75% by that time frame of 2028. And obviously that's been challenged by COVID, but it's still part of that ambition. We knew in South Yorkshire, particularly in Doncaster, we had a high number of people who were dying of lung cancer, presenting late, so their outcomes were poor. That's what drove this. So a programme was announced in the long-term plan for people between 55 and 74 who've ever smoked, to be offered a lung health check and then to have a low-dose CT scan. Sorry, there's an abbreviation there. So that commenced. We did the planning, and Richard, obviously, as a trustee who was supporting that, we finally got that up and running. And in fact, Doncaster has been pretty successful, and because of the successes of Doncaster, there's an expansion of the programme to 20 other areas, and we got assigned at Bassetlaw, Barnsley, and Rotherham would also, in South Yorkshire, we'd have the funding to expand that further. Alongside that, there's ongoing discussions about the lung health checks being part of a national screening programme. Although the consultation's yet to report, the National Committee did make a recommendation in the last 4 weeks to say that they're proposing that does move towards a screening programme. This captures some of the discussions we've been having. There wasn't just the hospital, the CCG, and some local GPs. The participants that were part of the planning to make sure that we had community, we had support from, well, as much as real estate people who owned land that we could put this on, was quite vast. It was quite a lot of effort that was undertaken to get the programme up and running. And in fact, this is it in action. And it is literally a mobile unit that either sits in. The first one, this is Rosington, and it was the Miners Welfare Club, if I recall. So that's where that person, but we've used leisure centres, supermarket car parks, and that was a picture of the first gentleman who went through the scanner at that time. So what are the outcomes? How is this, what's happened? Well, we've had 160 cancers confirmed, diagnosed through this programme, of which 119 are lung cancers. And I would argue these lung cancers would not have been picked up. But more importantly, not only have they been diagnosed, they've been diagnosed at an earlier stage to offer 3/4 of people a chance of a cure. I mean, that's why I'm such an advocate for this. As well as the lung cancers, though, because the scan sort of picks up a larger part of the body, there were a number of other cancers that were picked up: 16 breast, 8 bladder, 9 blood cancers, 6 upper gastrointestinal, 1 endocrine, and then 1 which was a cancer of unknown primary. So it's obviously it's picked up a lot of other things. However, given the report we've just received, and that the factors that lead you to potentially have lung cancer, also factors to for other diseases, we found a staggering amount of people who had thickening of the arteries on their heart. Coincidental finding. But then the impact of that was that once you know something, you've got to do something about it. So it put quite a bit of strain on primary care. But it was a good thing to find because once again, these are people who hadn't presented with illness of angina or high blood pressure, but have been discovered with this, and they get treated as primary prevention. So there was other conditions which have been picked up, lung conditions and the like. So that was an additional finding that this wasn't just a cancer screening, there were other illnesses that were identified. So there's some statistics about the number of people who were identified, who went through the screening scan, and some of them will have follow-up scans as part of the programme. It's a 4-year programme. But this slide really I wanted to capture was it was an opportunity to offer smoking cessation for these individuals. And actually working alongside the smoking cessation services, we've offered support for a significant number of people to give up smoking, which will benefit their life going forward. What did the patient say? Sandra's story, I'll not play it because I'll end up in tears again, because it is quite emotional to hear her story of she would not have come forward for this screening programme and how she was supported by every part of the system, you know, to go through coming to here in Sheffield to have her lung surgery. And obviously she's now walking around in the community feeling that she's got a chance of cure. So maybe share that later. So what next? Rotherham and Barnsley are about to kick off as well, but there's very much been a health inequality approach from the start. So even in Doncaster, we staggered it to start off in South Doncaster because we identified that was the most deprived areas and the highest smoking rates. Then we moved to North and East and then Central. And there's a similar approach being undertaken by the PCN networks, looking at, you know, who's going to benefit most from this. So it's just to sort of, you know, tie a lens up that we're using the data we've got available to us to target people in a prioritised way. So that was my slides. I am going to stop sharing that. The paper actually goes into some other elements of earlier cancer diagnosis that have been undertaken as well. Some bits that I will just pull out is working with the voluntary sector to engage with communities, working with local GP practices through their enhanced service, the behavioural science approach, which initially helped us recover some of the cancer screening after COVID, but has been expanded to other areas such as learning disability annual reviews and smoking quit. And then we've received funding through Yorkshire Cancer Research to promote the Cancer Champion programme, so that's been committed to as well. And we've also used the sort of data and the techniques to recover our two-way pathways as well. The team did ask for a number of recommendations at the end. One was to acknowledge the data we've got here. I should have got the chair and nice to bear with me. I was the SRO for the programme up until taking up my current role, so there has been a bit of a gap that we do need to identify as an alliance and as ICB as well. And yeah, I'm happy to answer any questions, but I thought that I'd take the time to show you how this is really making a difference to people's lives in South Yorkshire.
I mean, I actually really good for two levels. One is really great information. And I loved, you know, and it was targeted at the communities that needed it most because, you know, smoking is such an obvious area. That's some really fascinating data there, David. I think I'd be interested, the board would, in seeing that data in whatever it is, 18 months' time in the other areas, because this feels like a really powerful intervention. Gavin.
So, I had a question about the data. That 71% picking up lung cancers at stage 1 and 2 is really impressive. I suppose I was just interested in how does that compare with conventional two-way referral routes? Because also in the back of my mind, I mean, it's clearly not about economics, but it'd be really interesting then to work out what's the economic benefit of early detection. Clearly, there's a benefit to patients, but I think that would be really powerful to know that.
So 2-week rates is based on that you have a symptom that potentially could be. So you're at that stage already at that, and the conversion rate is 1 in 10 of people who get referred on a 2-week pathway. I suppose that's what they grapple with at the the screening committee, because it's a balance between, are you causing any harm, what's the financial benefits you can get. So I think that is to be fully reported on, but their initial recommendation would suggest to me that it does say.
We need to get into the mindset where we are looking at the economic underpinnings of the things that we're doing, because clearly this is a proof of concept, a proof of approach that we need to have an evidence base for.
Yeah, I mean, traditionally, lung cancer was found at stage 3, stage 4, and was inoperable.
Yeah.
This makes a massive change, that 3/4 of those cases being picked up are at an operable stage. Economically, it will probably cost us more, because palliative care for someone at end of life is cheaper than operation recovery and keeping them going through, but it's the right thing to be doing. And I guess the thing that I love about this is not just the cancer outcomes, it's that we've engaged with 17,000 people who have a history of smoking. They will get from alcoholic communities.
But it's that wider economic analysis, because there's all sorts of other benefits as well as just the early diagnosis of lung cancer.
And I just think this is going to be a real challenge for us, isn't it, around how do we evaluate marginal changes in how the health and social care system operates, whilst candidly we've got a huge slew of things, costs being incurred, which probably aren't as brilliantly evidenced as they need to be. So I think there's just this balance between entirely proportionate economic appraisal and evaluation of this sort of initiative, which absolutely at every intuitive level and probably very quickly you could demonstrate adds value. It feels like very much the right thing to do, but we've got to try and find that discipline to do that. Quite hard-hearted villain, my sort of job. How do you demonstrate the economic benefits of this? Because there's going to be a whole range of these things that we can potentially additionally invest in a really austere environment. And just getting that balance right between critically appraising the extant things we're doing versus these new things we're doing is going to be a real difficult challenge.
So this is nationally funded, this is additional money that we've received at the moment, but if it becomes a national screening programme, and of course we're mindful that Sheffield hasn't been identified yet as an area for targeting in this, so we need to work. We couldn't do it across the whole of South Yorkshire all in one anyway. We don't have the resource, we don't have the machines to do that, but that's the natural next step if we've done 3/4 of our places.
Lucy, and then
So we welcome the bit of the report that talks about identifying people who may benefit from personalised support, and it's really good to see that there's a proactive approach to picking out people, for example, with learning disabilities, serious mental illness, to make sure that there are appropriate letters and resources and information going to them. And also that there's work with the DCSC and to connect, for example, to faith organisations to try and make sure that the messages are getting to all parts of the communities. I was just wondering if sort of in future reports there'd be some data that would sort of show how effective that might have been. Also alongside data, maybe some feedback from people that had received that information or been targeted in that way to sort of understand whether or not that approach was effective.
Lisa.
I think Lucy's just said most of what I was going to say, but I was just thinking about the equity of access and getting those people that are at high risk. And I was just going to commend the model of taking the screening to those people rather than asking them to engage with a service in secondary care. So yeah, I think that was a great idea.
I think screening going forward will be altered by some of this work. I was involved in this work in Blackpool, and it was about going out to communities that made the difference. That really made it. David, thank you. That's a really good report, really helpful. Okay, item 13. Will, this is developing the South Yorkshire Integrated Care Strategy.
Can I share some slides, please, Chair?
And of course.
Just a couple, if that's okay. And can I deal with acronyms as well? Because I'm really mindful that with an integrated care system, acronyms have become part of my daily life. So if I deal with just a few of them, I think that'll be helpful in terms of the report. So integrated care system, ICS. So essentially that is a geographical boundary, that's South Yorkshire and everything in it that is health and care, including that which we do for our local communities. across Barnsley, Rotherham, Doncaster and Sheffield. That's ICS. Integrated Care Partnership, ICP. I'm going to talk about that. So that's the health and care partners coming together as broad as you can be. So health, local authority, voluntary sector, university, our combined authority, everybody who can do anything to support us and do more around that. That's the Integrated Care Partnership. And they've got a key role around developing our integrated care strategy, which we'll talk about. And then so Integrated Care Board, an organisation responsible essentially for the commissioning of health service and a lot of other stuff that we've been discussing. So I think there are three acronyms that I will talk about that hopefully I'll cover off. My computer will move and it won't. In the report that you've got in your pack, I've covered off two things. One is progress that we've made to establish the Integrated Care Partnership. That's really important. And the last time we met as a board in public was in September. At that time, the Integrated Care hadn't met. It was due to meet on the 23rd of September. So I think just updating the board on what happened since that is important. And then the work that we've been doing as an Integrated Care Partnership to start to develop the initial, I use that word very purposefully, the initial integrated care strategy, South Yorkshire. So just those two things. My slides would have showed you, they would have showed in simple terms what an integrated care partnership is. So I think it won't move on my computer for some reason. In its very basic terms, the Integrated Care Partnership is convened by this organisation, so the Integrated Care Board, and each of our local authorities, but with a whole host of other partners. It's really important that we have those broad voices and perspectives in that forum. So I think in very, very simple terms, that's what it is. I think it's really important to see it in that way, because not only is that really important in terms of how the integrated care strategy for South Yorkshire is developed, so all those partners, but it's also really important for our. So there's one thing about setting out a strategy, there's another thing about taking action to deliver the ambitions that are in it. So start there. If I could just update you on the establishment of the partnership, I think there's some important things that this board needs to both be aware of, but assured of as well, because we are a joint partner in that forum. So the paper just references first meeting on the 23rd of September. It was a meeting in private. It was a set-up meeting. It was a whole new set of partners coming together for the first time. The Integrated Care Partnership is chaired by our regional mayor, so Coppard is the chair of our ICP, Pierce is the vice chair. And I wanted on the slide to just draw a reference to the work that Barbara set out. I think that's really important, because one of the things that we have to do, and is absolutely critical in our integrated care strategy, is to make sure that it's based on need. And that which we know about that. So the report that Barbara's done is part of a bigger report, which is really helping us understand where we are as a system and a whole host of things, not least in terms of where we are in relation to population health and outcomes. And the slide I wanted to pull out for you is one that was used at the end of that report, which is to highlight one or two things, which is actually our population don't get a fair deal. And what I mean by that is people die sooner than they need to in South Yorkshire. And I think that's hugely important for us to draw out now. It was drawn out really clearly for the Integrated Care Partnership. And it made for quite sombre reading and discussion actually at the first meeting. And we were challenged actually as an Integrated Care Partnership by our chair on, well, what are we going to do this time then? Because that's not new. The fact that our population don't get the best deal is not new. And we're doing tons to try and change that, but actually we've still not managed to. And I'm saying that because one of the asks really of all of us was our commitment to be hopeful but also be committed to try and work differently this time round to be able to really change what we find ourselves in is that people die too. Choosing one of the bullets off Barbara's slide, but also it was reflective of the huge amounts of health inequality that there is across South Yorkshire as well. And we know that because when we established on July the 1st, we adopted the Health and Care Compact, if you remember. So that was our commitment for the health and care system to work on some of these really, really tricky issues and to work very, very differently. And our commitment to what is described as a quadruple aim, but essentially that's the four key purposes of an ICS, which is to improve population health outcomes, to really tackle health inequality. Do what we can as well to work as a good partner with others, so that broader perspective. But essentially, it's about what do we do this time that's different. At that meeting as well, and I think it is in the pack, we set that out in terms of how we work together. And just to remind you how the membership of the Integrated Care Board was put together came from a recommendation from each of our health and wellbeing boards. So each of our health and wellbeing boards nominated 5 members. So 5 members, very much locally determined. With the ICB being able to then consider additional membership, particularly when you wanted to get perspective across South Yorkshire as well. The reason why I mention that is because there's still some work to do on membership. So whilst I've asked you to consider and approve the constitution of the Integrated Care Board, the discussion that was had in public on Friday was, have we got the membership quite right? And that was on 2 counts. 1, diversity. So we were ambitious about the ICB not only representing the voices and perspectives, but also being diverse and reflecting that community. And we felt that there was more to go on our ambition around that. So there was an action for all of us, but also for our health and wellbeing boards to look at their nominations to see whether there's anything more they could do to ensure that we were able to reflect both the voices and perspectives, but also the diversity. There was also some gaps we brought in that, and therefore there was some action for the combined authority to do, some action for the Integrated Care Board, and indeed some action for our health and wellbeing, particularly in relation to the voluntary sector. There was a very clear message that we needed to have more voices and strengthen membership representation of the voluntary sector, but also from other areas as well. The mental health we thought was a voice and a perspective that wasn't strong enough, and therefore that was an action for the Integrated Care Board. But also the university and education sector felt like that was missing too, and also athletes and fire. So I just wanted to give the board a flavour because I'm mindful that I've asked you to approve, but there's still some more work to do on the membership. If I move to the integrated care strategy, it's going to be quite tricky there, but I'll do my very, very best if that's all right, and I will refer to them on my.
Moving well. They're still on that piece, but not full.
So if I put it onto full, it won't.
Yeah, that's what you need.
Okay, I'll read it out because it's actually very, very small. So I wanted just to make sure that I've just gone back a step just to make sure that we were all clear on some of the stuff that we're going to have to do and the really challenging time frame that we've got set out. So by December, and we are now in November, aren't we? We are asked to set out our initial integrated care strategy for South Yorkshire. One of the things that we did discuss as an integrated care partnership and reflect on is all of the work that is already happening across each of our places and indeed across South Yorkshire. So the fact that we already have really strong and effective health and wellbeing board strategies and strategies and plans across places and South Yorkshire. In fact, we have still some time to go on our health and care strategy across South Yorkshire, which was a response to the long-term plan. And the reflection was that it wasn't necessarily a new strategy that we needed. Actually, they are reflective of the things that we need to do. We needed to think really hard about what can an initial integrated care strategy do that adds value to that. So in other words, what can we be really clear on what we need to do as a collective partnership, and setting out both our ambition and a small number of strategic priorities that build on that. They don't smother the work that we're trying to do. They build on it, they add value, they enable us to go further and faster. So the focus from that first meeting has been on really starting to think about what those ambitions and strategic priorities would be value adding. This is just reflecting on the headlines of what's expected of those initial integrated care strategies. Before I say that, there was a question about whether we did one. And if you look in the legislation, there is a choice for systems in some respects, because there is a choice about whether things have changed and whether it's needed. And I think there is a view that a lot's changed over the last few years, and therefore actually refreshing our strategic priorities is really important. However, it does give us a lot of flexibility because we are a large system. We're a large system with very discrete places covering our community really well together. And in effect, we have health and care partnerships working in all of our places. It's just helpful to reflect back on some of the discussion that we've had today and some of the things that are expected of us in our strategy. We talked about some really key commitments and outcomes within the discussion around what would it look like then to focus in on some areas of focus for South Yorkshire. And I'm just sharing with you very live because this is really just coming out of the discussion on Friday. It's not determined yet, but just to give you a flavour. And so on the screen, you can see there that best starting life for children, really seen as an important area of focus for us. Enabling people to live longer and healthier lives, improving the health and well-being of the poorest and most vulnerable, the fastest, and support people to live in safe, strong and vibrant communities and equip people with the skills and resources they need to thrive. So these were some key areas that we've seen as really important for us to think about. And what we've started to do is thinking about, so if we were to develop some bold ambitions around that, what would they look like? That work's not been done yet. It's still evolving, but I'm just wanting to give you a flavour. When we talked about some of the bold ambitions, we talked about, so what would we have to do? And I think we've had quite a lot of discussion around prevention, early detection. David's just given a really good example of what early detection can do. It's not just early detection in terms of health, it's also well-being. So how can we detect a whole host of other things, whether it's people in their own homes who are at risk of falling, it could be anything. So really thinking of it in its really, really broadest sense. So there was a discussion around what some headline broad ambitions would look like. We're thinking about these really broadly, but across the whole of our health and care system. But also thinking about what does it mean to work with a health and care partnership that combines all of those different perspectives and pulls together all of those different strengths, including working with our combined authority and really getting that connection between health and work and our broader role around making sure that we participate in that broader social and economic perspective. What can we do? So there was some early thinking around these areas that I'm showing on the screen here. So prevention and early detection, our health and care workforce, which is our greatest asset, but at the moment probably our greatest challenge as well. We have, if you just look at the health and care sector, potential, 72,000 people working in that sector, really, really big employing organisations. How do we really connect that with the great opportunity and great jobs? Economic inclusion, really good connection in terms of making sure that actually everybody's got access to and the opportunity for great work. Just wanted to share a bit of a flavour of where that discussion's got to. In terms of what happens next, so literally trying to pull together the write-up from the work that happened last Friday, so that we can start to pull together some of the vision and the ambition and some of those emerging priorities. So that's that. Another key piece of that, which has already started, is our involvement work, massively important, and a big focus in the guidance that came out as well. So just to update you on where we've got to with that, the ICP thought it was really important to make sure that we start with that which we already know. So not asking people, our public, the same things that we've already been asking them. So we commissioned an independent report to help us really understand where we've already engaged and involved. We managed to do that. 248 pieces of evidence, or 248 reports, given some rich insights as to what we've already asked and what our public have already told. And just to give you a sense of its very headlines, really big theme around awareness. So our public are asking for information to enable them to be more aware and be able to control their own health, particularly around prevention. There's a big theme around access. So access to support tools of all sorts, and in our communities. And also another one was agency. So this is about, again, this is about not only tools, but actually enabling, really massive enabling roles that we can do as organisations to enable people to really both really support themselves well, but actually be supported well. So just giving you a flavour of that. As part of that, we've also started a campaign, public campaign that started just today, I think, and gone live today. So that's really trying to keep that really simple. That's trying to reach as many of our as possible. It's asking a very simple question. It's asking the question about tell us what matters to you about your health and well-being. So really simple. And the advice was that we keep it really open and simple in that way. And we will obviously make sure that we try and capture that as it comes in over time, so it can actually feed into and shape the strategy. And then the final one is that the third piece of this for this bit of the strategy is to try and get some real deeper insights. And that's the work that we watch and our voluntary sector who know how to do this really well, have the relationships, and can really connect us with people with lived experience, so we can get those deeper insights. So that just gives you a flavour of the engagement and involvement work that we're doing. So November's going to be quite a busy month because that's one part of, critical part of our engagement involvement, and then of course there's the engagement involvement of our partners as well, and sort of testing some of the early thinking around some of the ambition and some of the priorities that are coming out, but also the work that we're doing to try and really work out, so how would we know we've been successful in this strategy? So starting to develop some of those key success factors in that as well. I'll leave it there, and I'm very happy to take questions.
Excellent. I think Will's picked up two issues really. One is the ICP and its development, how that's gone. Secondly, the development of the strategy by the ICP. That's fair, isn't it? So any questions from Will on that, or observations? And a number of people around this table are also at the ICP meeting.
Yes, I'm just going to pick up the last point you made, Will, around the involvement of the public, I think is absolutely critical. I mean, clearly this is it's a sort of incredibly tight timescale. I guess it's the good news, it's building on some good foundations, the health and wellbeing strategies that have been developed in different places, the 200 odd studies that have already been done and those views, and also I think the campaign that you're launching today. So I think, despite the limited time, I think we're making a good effort. But I think it was your point about this isn't the end of the story. This is a sort of our first, articulation of a strategy, but I think it will develop further. And I think incorporating that involvement of the public is going to be absolutely critical going forward. But I mean, really good to see the work's being done, in spite of the incredibly tight timescale.
But I've got a lot of questions about engagement, and I'm going to ask you if you've answered them in what you said to me, what you said to us today. So thank you for that. I think I just echo what Gavin's saying. I think it's really important. Timescales are incredibly tight, but any engagement has got to be meaningful. And so, in a sense, it's about telling stories, isn't it now? This is the start of something, not the end of something. And people being aware of what's going to happen to the information that they're providing, also how we report back to the communities that we serve about what we've done with the information that they've given us, because often we don't close that loop. And so people think, well, you asked me what I thought, told you what I thought, what did you actually do with it? So I think, we need to think about that, and I think we need to think about just getting some assurance on that. So I've just made a few notes about the patient public involvement and engagement as part of the committee that I chair, just to come back on some of it more detail. So, but thank you. Yeah.
Got Lisa, then I've got Lisa.
Thank you very much, Bob. Excuse me. I think just looking at this and looking at inequalities and thinking about Barbara's report as well. I'm glad that you mentioned the workforce and stuff like that. And I think Gavin's report mentioned that we've just celebrated Black History Month. And I think the thing that stood out for me the most were the stories that some of our staff told about their experiences. So while we're looking at inequalities, I feel we should start at home first and think about the experience of our staff and how we protect their mental health and well-being in their roles, and what we do as a system to support kind of fair treatment and behaviour. And I think if we get that right, then we probably get the recruitment right, because then we have a culture that supports people from different backgrounds. And I think once we've got that right, we can better serve the community. So I think we just need to sort at home and have a strong strategy to deal with that.
I was in a conversation last night about if it's 72,000 staff, and by the way, that excludes care staff and NHS staff. And each of them have got, say, you multiply that by 4. Actually, if we engage those as people who went out to do our things and felt good, it's a hell of a proportion of that stuff. We don't always appreciate the power of our own staff. Good and bad. We need to get that right. Lee.
I think that's a really helpful update, Will. All I was comparing is if you look at the sort of priorities that came out of the first ICP meeting, and I'm a bit of a side, as you're well aware, I was looking back at the 6 broad recommendations from the 2010 Marmot Review. They're not hugely dissimilar. And there is something, isn't there, about how the English NHS does strategy. The trick here is going to be, how as a learning system and organisation do we compare our plans to affect this strategy? There is something around what's the good enough definition that 42 ICBs are going to describe in that strategy, and how we operationalise it. And there is something about engagement in the development of strategy of something tailored to South Yorkshire, but there's something quite important as well about how are we going to compare our implementation approach in a relatively standard way with 41 ICB colleagues, where candidly the human anatomy in Derbyshire is not hugely dissimilar to the human anatomy in South Yorkshire. Different challenges. So I think there's something about, it amuses me on occasion about how the English NHS does strategy, because to what extent you've got to tailor it locally versus it needs to be comparable so that we can compare performance and how we're operationalising the strategy. I just wonder if we do some influencing others. I didn't know if that would be helpful, Jeff. That's what I'm saying.
David.
Yeah, somebody who lives in Derbyshire and works in South Yorkshire, you can draw your own conclusions on that. But I mean, I would certainly support the point that you make about strategy. And if you're not careful, I mean, there are strategy, there are four or five P's really. If we're not careful, we don't go on the first one, which is plan. And I think the one that we were talking about earlier, which is patterning, is absolutely critical in terms of understanding of insight and the differences and the intelligence that informs what we do. But I also think there's position, how we adopt a disposition towards a number of situations or indeed issues that we've just been talking about, EDI, equality, diversity, inclusion. But there's also, I think, ploy. There's far more that goes on in terms of the ploys that we enact than there is around sort of using another P that I've already bad now, pathways. And then the final one for me is perspective, and that's largely around leadership and management and how it is we bring across the system that leadership. And I think those are much better sort of guides for me anyway in terms of the how we go about doing things. Then otherwise we end up with a rhetorical plan and we come back at a periodic moment and we're held accountable for it. So we did this, and there has to be more dynamic, I think, within that, which is why I think the idea of it's the start of the story, not the end, and that actually this is a running video, not a set of snapshots, and how we enrich and visualize that. And we see, one brilliant visualization and another one that's promised around Sandra's story. These, for me, are the touchstones that we need to be embodying within the strategy on a regular basis.
The other point, to pick up a couple of things. One is, I've been really gratified by the way the ICP seems to have taken off. There's a real commitment from our local authority leadership, for instance, from Oliver to make a real difference on that, and also from the voluntary sector. So it's got real promise. The second thing is that, did we need to do a strategy? I've been really pushing the idea that we do. The reason for that is I have a real fear that if we don't have an overarching strategy to guide us as an ICP, we will get driven by the centre to do nothing but the operational stuff, which we talked about earlier. I'd rather have a high level strategy that guides us on health inequality and on making a difference, hold ourselves to account than have nothing and find we get totally driven by important stuff like ambulance waits and unemployment waits. I'd rather have that in place in January when I go into what's our plan for next year and what's our strategy for 2 to 5 years. If we don't have something that guides us long term, we will get driven around the ship. I was very clear about the ICB, and the ICB get that. So this is not a finished document we produce in December. It's something that remains with us for quite a while, but it's critical that we get something that guides us, because this board has every right to take the exec team. Your plan for next year, how does that fit with the strategy we've just signed on? And that's actually a really critical bit of architecture almost to this organisation. So, Will, thanks for the work on this. I think it's really important work. I've just realised we need to come back and think through approval by board processes, but actually that's a bit of work we can do with this. So thank you for that. Okay. Cost of living crisis. Verbal update. Is that from you, Chris?
Yeah, myself and Ben will do a double act. I'll just do a quick update on where we are in next steps, Chair. So there'll be a formal report next time. So we started off. So I should just say we've had 4 reports already on cost of living in each of the places.
Yeah,
so I won't go into the detail of the here and now. Assume people have got that. And this is how we wrap it all together and how we move it forward. So it's important to just to note when we started this is how do we respond into a spike in energy costs and a short-term issue. And obviously now things have evolved and we understand now we've had interest rates increases. The latest economic forecast is we're going to see an economic downturn probably to the end of 2024. And then the health and wellbeing impact will be way beyond that. So we're into a long-term plan now, not just a short-term reaction to this issue. So we've got the short-term issues. We've met with the 4 directors of public health who are showing their great leadership in this area. The 4 local authorities very much showing leadership in this space. So what we're doing is we're working at place across healthcare and wider partners to come up with the cost of living response plan in each of our 4 places. That's currently going through governance arrangements, cabinets and the like. So our intention is to bring them together, come up with a sort of a coordinated South Yorkshire response. Then we'll reconvene the DPHs and look to see if there's anything we can do on a South Yorkshire, anything would add benefit to be done on a South Yorkshire footprint. I mean, certainly to share best practice is an absolute minimum, but there may be some areas we wish to explore. So hopefully we'll be able to do that in the coming weeks. Our intention would be to bring a more formal update report to our December meeting if we choose to meet to the business meeting in December. So Ben, is there anything you want to add to that?
Yeah, I mean, the conversation Chris and I had this morning was really, I mean, I think that's broadly where we go. It is that, and the point we made earlier, in South Yorkshire, in two-fifths of our population, and that mostly by Quintal, cost of living isn't an issue. It's just this winter. It is a long-term issue for us in South Yorkshire, for everyone, but particularly for us in South Yorkshire. So I think it's things we're already dealing with, things we're there, and I think what this work will do is just coalesce what we can do as a system in the short and that, making sure we're plan for it and that we are aligned in what we're doing across the 4 areas. And I guess the other bit say in terms of where we are local authority wise is just when you shared in your update the web address that they've got for Barnsley, all 4 local authorities have got web resources there, and what we're trying to do is make sure you're not inventing other resources and other things, and we're all signposting through the same resource in each of the 4 areas.
So we would expect this to come back when the work, to come back to the board with the more overarching work when we see what's being done.
That's right.
And I guess, as you said, the other issue that we probably didn't start off thinking this, is this now feels like a longer term issue than a short term.
Yeah, we need to come up with long-term sustainable solutions and not just winter solutions.
That's really helpful. Christine.
I just wanted to add to that, we intend to include the workforce elements of that in with that report, given that we know that a large proportion of our workforce in South Yorkshire probably our population in South Yorkshire as well, so it's important we bring the two together.
Any more asking questions around that? Thank you, Chris. The target operating model, we did actually take the board informed me through this on Monday. Don't you want to?
Can I just do a 1 minute update just to we're in documents? So sorry, for people who weren't present, I did a development session on Monday for board members. So just going into the details. So I'm just going to give a very high level summary, but obviously people feel free to ask questions. So a target operating model, it's something that seems very good practice for complex organisations. We are undoubtedly a complex organisation. The idea is that we started 1st of July, we landed safely from clinical commissioning groups coming into the organisation. But the next step was for us to organise ourselves to deliver our statutory duties and key objectives. This process of coming up with a target operating models to make sure all our staff stakeholders have absolute clarity on our purpose, vision, value and behaviours, our objectives, our governance arrangements and our functions and delivery approach. But the idea is this is a start. This is getting us to the start line of the organisation, and it will evolve over time. You know, we'll work with NHS England to talk about how we develop performance management regimes. We'll talk about planning as part of the ICB, and we can evolve this. But this is meant to give us an operating model to start with, as we are now. Our intention is to move to this by the end of November. So there's just sort of 3 key next steps for us. Is to complete the human resource processes to make sure everyone is moved into the delivery structure by the end of November. Particular issues will be around just forming one corporate function, forming one digital data and business intelligence team, one partnership communications and engagement team, and one people culture human resources and OD team. And then the next step, looking at Christine, is we need a training and development plan and an organisational development plan, which makes sure all our staff stakeholders, we can all go on the journey together and make sure everyone has the appropriate support and we have a clear plan for staff development. So that's where we're at, Chair.
Any questions, Will?
Yeah, thanks for that, Chris. Just to add to that, really, because we did actually make decisions. If you think about how we've established ourselves as an integrated care system with all of those partnerships, our collaboratives and alliance, took a conscious decision to really see places as the foundation stone. And I just wanted to add that to Chris's report, because actually the way that target operating model in essence reflects that, because we haven't actually made a massive amount of change, because we've actually reflected that. And, in many respects, all of our people actually are in a place supporting place work. So in other words, we have to think quite consciously about the stuff that we've had to do to recognise that we are one organisation as well across South Yorkshire. So I just wanted to say that, because actually, that sort of way that we've established ourselves is really, really important, because that actually was the starting position.
Lucy.
Yeah, so I'm coming to this as someone who hasn't been part of the conversations previously about how it's been developed or what it means. And my sort of observation would be that it's actually quite hard to understand what this means in any tangible terms. And I'm sure there's a whole load of information that sits behind it that supports that. But as you're like an external fresh pair of eyes on this, it's incredibly hard to understand. So that's my first observation, and I appreciate there's a lot more that sits behind it. So having sort of factoring that in, sort of making what might be quite face value comments and observations about what I might have expected to see in there that I can't see. It doesn't mean to say it's not embedded in there or hidden in some way, but the things that I would have expected to see would have been more explicit mention about where equality sits. So we've talked about the golden thread of inequality, but when you're looking at sort of the matrix of where the sort of different functions are, there's no explicit reference of equality or who owns that and who sort of looks at it. And also patient experience is the other sort of glaring omission for me as a, from a Health Watch perspective, we would have expected to see those words or that function sitting in there somewhere in a sort of visible way. So those are the two omissions that I sort of spotted, but with that caveat of I don't actually that well understand the whole document if I'm really honest about it.
Thanks, Chair. Can I just respond?
Yeah, please.
So, that's fine. I think what I should have said is the target audience for this document is of the 900 staff we work within our organisation. It wasn't meant to be an externally facing document. So it's coming here hopefully to assure people that we're organising ourselves internally. We've had that feedback consistently at the development session as well, that we probably need to do another iteration or some communicated in a way which the wider stakeholders and partners to understand what we're doing. In terms of the equality and engagement, so it is covered in we have a function which is, Andy, it's your function, isn't it? Do you want to just explain how that function works, how patient engagement's covered in that?
Yeah, so within my team, but also within other teams, there's colleagues that have got equality within their job description, and I think equality overall sits within Christine's remit. So we're working really closely together to bring our teams together to understand our offer to the organisation. But I think, as Chris has said, this is the very earliest step in this. So understanding what those colleagues are working on at the moment, what their priorities are, and how my wider team can support them. So I think you're absolutely right to say you don't understand how it fits in. I think we've got to do that body of work over the coming months to answer that question.
Thanks for that feedback. That's really
Just to reiterate what I said, this is effectively an internal document for our staff to say, we wanted to reach a point by the end of November, everybody knew who they reported to and what their job was. Because actually we took over 5 different organisations in reality, core of people who were working for the ICS, as well as staff who were working in 4 CCGs, remember Bassettville, just to be clear. We wanted to be able to say, this is who you report to and this is what your role is about. That's what this document is about. Not meant yet to be an external document. When we talked through informally with the board on Monday, we also said there's probably a need for another document, which might be a few months away, particularly with the development of place, that says externally facing, are we clear now? Place is responsible for this, the alliances are responsible for that, federations, if you like. Actually, I think that's something we will need. We need to debate when that is, because I think there's something about devolution of place. Are we going to give more out to it? And that might be a document for the first quarter of next year. I think that's a conversation. This is a document that's, if you like, saying to the board here today, all the staff should know where they report and how we operate. Stop. I think there is something more we need to do externally. But I mean, the message on equality is really important because they do matter to us. If we haven't reflected it, we've got it wrong. But I think that's just, there is something else I think we need to do externally, which followed the work that was done before the start of it. I think we want to revisit that.
Just emphasize for the patient experience.
Absolutely. Yeah, Lee.
Yes, I think Lucy's point is slightly easier than that about what you haven't got within the paper is what's the functional accountability where those words do exist with each exec director. So we were looking to are we discharging those responsibilities once across the ICB or 4 times within place? I think that will create that connection. You know, it doesn't invalidate a document that flows from this that says that a bit more clearly, but I think we can create those connections.
That's all become
more quickly.
Okay, Chris, thank you for that. 16 primary delegation update. Anthony, this is about, if you like, work that's coming our way. I've described this. Is that fair?
It is. That's a great way of describing it. Thanks. Thanks, Chair. I was just going to take the opportunity really to update the board really of the preparations we're undertaking for delegation for dental, optometry and community pharmacy from April 2023 from NHS England to ourselves at the ICB, and some of the work that we've got to go through now prior to April. There's a number of papers, my apologies in some ways, with this 33 pages. I think is a lot there, but really what it describes is the way that we've worked through this approach with our South Yorkshire leads, with NHS England, and discussions with other ICBs across North East Yorkshire. And we've taken these and approved them appropriately through our operational executive team. If I could just very quickly guide members through those. Appendix 1 and 2 is a briefing paper and also a pre-delegation assessment framework, or a PDAF, that we submitted as part of this process. If I can summarise, I feel that we're in a good position. We've undertaken the required due diligence in terms of finance. We have a good relationship already in existence with NHS England staff working on a South Yorkshire basis already. And we have preempted the April with our involvement of clinical and managerial teams regarding dentistry, pharmacy and optometry already in our work, particularly with our fledgling primary care provider alliance. And those groups will be heavily involved with our primary care strategic refresh that we're undertaking at the moment. However, due to the sheer volume of the work that this brings, and it's over 900 contracts across South Yorkshire, the main risk that we've flagged is that to do this properly, we've emphasised the need for the expertise and fully funded resource currently within NHS England being available and coming across to the Integrated Care Board. And we continue to work through this with NHS England, and it is a risk equally shared by our neighbouring integrated care boards. Chair, if I can briefly describe dental, and that is on page 27 of Appendix 4. Given the limited size of the current NHS England teams, the complexity of the dental contract, which I've been trying to get myself up to speed with, and there are again, limited expertise that we currently have in the system. We're recommending, we looked at a number of options in terms of the initial commissioning approach for the ICB from April for dentistry, and we took that through our operational executive team. We're recommending an approach where initially dental commissioning is delegated to the 3 Yorkshire ICBs, with commissioning taking place across the Yorkshire and Humber footprint, but is undertaken by NHS England commissioning hubs on behalf of the ICBs. Now we're working through a number of options, a number of scenarios of how that might work in practice, and we're going through that. The other thing I might say is that might be initial approach for year 1, but we might look at it more on a ICB by ICB process as time progresses, as we become better at that. I suppose the next steps are working through the safe delegation checklist. We've submitted these documents to NHS England, and there is an NHS England board in December that will make the recommendations based on the initial work that we've done. As I say, at the moment, I find us really quite confident that we can land this in a safe place. But that's my point. My last point really is that we shouldn't just be looking at safe here. We want to take advantage of the opportunities that this delegation brings, particularly around transformation of the way we engage with community pharmacy, dentistry, with optometry, bring those providers together to look at how we can transform pathways, David, and better outcomes for our patients across South Yorkshire. So it's really a position statement, Chair, of the workers.
Really helpful. I mean, it's two things. One is that we had this with the ICB. Let's land it safely. People get paid, real basic stuff. And secondly, then get control of it and begin to think about running services differently. We all know the issues around dental services, most places. I always think of the opportunities, opticians, operators that we simply don't use. There's a lot we can do to transform this. First responsibility is landed safely. I guess the only question I've got, Gavin, is that I wouldn't mind seeing some non-executive view of safety on this around it. To get a separate view, can we think up outside how we do that? I just think that would be something that would give me some reassurance as chair. Kathy.
Yeah, I just wanted to, I know Anthony started on this, but the whole complaints function around this element of dealt with by electric things at a regional level. Now, the majority of those are around dentistry. So we have no idea, as far as I'm aware, of what the thematics are in relation to what we'll be taking on from the South Yorkshire perspective or the workload, because that will also. So I just want to make sure.
And you're feeling that's a huge workload, aren't you?
We know. So we're waiting for data from the regional team, but also there's a almost a transition group being set up. But at the minute, it's kind of being pushed down the nursing route. Well, there's an ICB that doesn't sit with me on my portfolio, and I think it just needs to be really booked in. So one, we understand what the workload is. Two, we understand what the quality and safety things are, because actually that will then help any of our sort of their colleagues that want to have an overview on that. And I don't think we've got that at the moment.
Reinforced by the, can I get some non-exec involved with this?
Yeah, it's more or less along the same theme. I believe you mentioned opportunity down traps. I'm trying to think, well, we haven't any choice in this.
No.
You know, is this a chore or is it a real opportunity? And I guess that will come. That's lift and drop for safety. But I think before we do sign on the dotted line, whenever that is, I think we fully need to understand the inherited risks and issues of this. And I can see in the paper clarity about there's an assumption here that we'll get the resource and the expertise that goes with it, and it's got to be dependent. This can go wrong very, very quickly.
And that was my point about landing it safely.
Yeah.
Was really keen, as you can see through the paper, to emphasise that point, and that's shared with the other ICBs as well. Yeah.
So a greater exposition of those risks, those inherited issues that we'll pick up from day one. Yeah. I think it's really important. So maybe through the committee structure.
Can we think about how we do that?
There's just something about, I mean, you referenced due diligence, but it kind of cuts both ways. There's something that I agree what the offer is, what's the budget around complaints is, for what resources to move across to manage that workload. So absolutely right.
You see them, Ben?
Or for an item on dentistry, say something about that. It is one of the biggest issues that comes to us at Health Watch day in, day out. You know, it's a massive issue for the public. And what I would say in response to the point about complaints is I think at the moment it's slightly shrouded in history, how people can actually influence or have their say about dentistry services, because the commissioning of it has been somewhat remote from the places that people live. So I think that has probably actually, if anything, reduced the amount of complaints and issues that are coming through in formal routes, and there's a lot of informal feedback that never gets to a complaints phase, that actually if people had a clearer route and knew where the kind of power lay to make decisions and changes to the services on offer, you might find that there's actually more coming through, and rightly so, because it's impacting on people's lives in the most enormous way. So yeah, from our perspective, I think it will be a positive thing for the accountability to sit closer to where people are, but just to be aware that I think that there will be a bit more of this touched on, I think.
I think particularly, but not exclusively in dentistry, we will be taking our responsibility for commissioning a system that most people think isn't working very well. That's what we're taking over. I think the words chalice and poison comes to mind. Actually, that might, the issue I don't yet know, I don't think any of us yet know, what chance does that give it to reshape it in a way that is better? But I think none of us are under any illusions. we would be taking over responsibility for community dental services that look in a mess. The public sees this as one of the biggest messes in the NHS. Thank you very much for the delegated authority. But actually, the ICB should take it over and be determined to do it better, because that's what we should be about. But I don't think we should be under any illusions of the scale of what we're taking over. Chris, and then I've got
Just a quick comment. Someone who's been around a long time. We have experience at Dental Commission. I mean, 2012 is when it went to a more regional national footprint. Kevin, your challenge is a chore and opportunity. It's clearly both. It would be something we'd have to consider about what our resources were impacted on that. We will receive sort of as is service, but there's huge opportunities in terms of health inequalities, in terms of dentistry, certainly in terms of urgent emergency care pressures. There's massive opportunities there. So I do think it's the right thing to do, but the due diligence will be crucial, because there'll be big financial issues, there'll be quality issues, but the other thing is about resources and where it sits in our priority being the key discussion.
Yeah, just to add to the resources stuff. So pre-2012, we used to have a South Yorkshire Dental Public Health League, or possibly two across South Yorkshire. They all went into NHS England. There's now, I think, 2 or 3 people from North East and Yorkshire. So it's where does that capacity come back? Because local authorities through health and wellbeing boards do the pharmaceutical needs assessment. NHS England took responsibility for all the health needs assessment, and usually that needs to come back through to the ICB and to local areas again with that. So just making sure we think about that.
Helpful. I think what we've got here, thanks for the update. I think there's a genuine view that actually this is an issue we want to make better, but we're real concerned about workload, due diligence of what we're taking over. And as I said, I don't want the board to be under any illusions. Land it safely, then think about changing the service. We will not be thinking about changing the service from day one. But I do think dental's a really good example where actually our public think this is poor. Can't we make it better? Got to be the challenge, isn't it? Got to be the challenge. Anthony, thank you for that. And I'll pick up with Gavin how we pick this up in our committee structure. I would like to see some non-executive director scrutiny around this, because that would give me. Thank you for the report, really helpful. Okay, items for information, minutes of the Doncaster and Rotherham Place Committee. They're just for noting, is that okay? Thank you, and I don't think we've got any other business. Okay.
Just to remind you.
So we've got next meeting here is the 4th of January, but we have a meeting at the beginning of December, and we're likely to make that a public meeting rather than just a private meeting because of some of the stuff we decided we have to take through. So the meeting on the 3rd, I can't remember what it is, 7th of December will be a public meeting for everybody, please. We've now got a couple of private briefings for the board, which we'll have to do in private. So the formal meeting will finish if we can take a 5-minute break. The public could leave, and then we've got a couple of private briefings. I don't think they'll take very long. Thank you. Members of the public, thank you for coming.
Chair, you might get down to 12. 12 after this.